All right, great. So we'll cover all of endocrine today. We're going to go through the slides, and then Lindsey is going to do questions with you guys after. Some of it we're going to record it. So if I go a little fast, the recording will be posted. But by all means, if you need clarification or if I say something incorrectly, just chime in and we'll make sure everything's clarified. All right, so as you know by now, I'm on Scrubs. Lindsey runs Dog Mom. We put some extra stuff on our drives too that have old questions and some of the things that we found helpful. I'll pull out some of the slides from first aid that I think are super helpful and just post those there too. All right, so we'll start off kind of broad and work our way through this. The endocrine system, of course, you know you have an anterior and a posterior lobe to the pituitary gland. The hormones in the anterior lobe are actually synthesized there, whereas in the posterior lobe, it's the neurohypophysis where the oxytocin and ADH are actually synthesized in the hypothalamus and just stored in the posterior pituitary. And you can appreciate here, I think I have a larger slide of it, but on the posterior side, this is neural tissue. So it stains a little bit lighter, the myelin and stuff, it doesn't actually stain well. So you can see that it's a lighter stain. And the anterior lobe is more granular. Okay, oh, and you can see that here, right? So it's a granular appearance in the anterior lobe. So if they ever give you a question that says something like, it's blah, 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 is synthesized in the pituitary, just know that you're restricted to the anterior lobe. And like I said, the posterior lobe is going to be storage. Adenohypophysis is anterior, neurohypophysis is posterior. This is a good slide to remember too. You can see this is kind of like that delineation between the posterior and the anterior lobe. Again, the anterior is more of like a granular appearance. And you have this fibrous appearance and this lighter stain of the neural tissue. So by all means, like I said, this is definitely testable, a good histo slide to represent the pituitary. So when we break down the anterior lobe, you can, this is again, another really important histo slide. The acidophiles are going to stain pink and the basophils are acidophils and the basophils are going to stain, the basophils will stain purple. Chromophobe means color hating. So they're going to stain in a lighter stain, whereas the chromophils, like I said, are going to pick up the color stain. So there's a good mnemonic to remember this, the flat pig. So remember that FSH, LH, ACTH, and TSH, those are going to be your basophils. So you can remember B flat. That's a good way to keep it in mind. And then the prolactin and growth hormone are going to be the acidophils. So acid pig. That's a good way. And again, remember the acidophils are going to stain pink and the basophils will be purple. You can see that here. All right. And then this is just going into a little more detail. Some other terminology, somatotropes relate to the growth hormone. And then mammotroph or lactotroph is more about prolactin. One of the important things, I put the mnemonics again here. One of the important things to remember here is that it may not be intuitive that the prolactin is actually, what stimulates prolactin release is the thyroid releasing hormone. And we'll look at one of the examples if you have a deficiency in your thyroid or that can actually affect your prolactin. So, and then corticotrophs, think of the adrenal cortex, ACTH. So we're thinking that cortisol pathway and thyrotropes is actually for the thyroid. Right, and we mentioned that. All right, yeah, the only thing I wanted to place here is we're talking about with the posterior pituitary. So from the supraoptic nucleus, you have ADH and the PVN is oxytocin. SAD-POX is an easy way to remember this. So remember, these are simply stored in the posterior pituitary. They're actually made in the hypothalamus. I know I'm going through this kind of quick, but this is a lot of review or a lot of the basic stuff. Right, again, synthesis versus storage, and here's some of those elaborated mnemonics that I like. Okay, the portal system for the pituitary isn't terribly important, but one of the things that's testable, the idea of a portal system is it's a venous system that divides into capillaries that drains into another venous system. So opposed to having artery, capillaries, vein, it's actually a venous portal system. So vein, capillary, vein, but this actually supplies the pituitary here, where in the superior hypophyseal artery will kind of go to both of them. You can see here, inferior is kind of restricted to the posterior lobe. Now we get into some of the disease patterns, and I put a star here, but we're going to break these down in a little more detail going forward. Okay, so let's look at the adrenal gland. Now it's broken up into the cortex and the medulla. Primarily when we talk about the steroid producing hormones or cells, we're going to talk about the cortex, which is derived from mesoderm. The medulla arises from neural crest cells, and that makes sense because the medulla is going to secrete those catecholamines. So we're talking about like norepinephrine and epinephrine. So it makes sense that they come from neural tissue or neural crest cells. So keep that in mind in case they ask you any sort of embryology questions. And when we break down the adrenal cortex, it's GFR, if you remember, like glomerular filtration rate. That's kind of how I like to remember it. But the mnemonic is the deeper you go, the better, or the sweeter it gets. Salt, sugar, sex. So if you keep that in mind, I have another picture, a histology picture to kind of show. But what's good to remember is that zona fasciculata is a lot thicker than the glomerulosa and the reticularis. So if you're trying to delineate them, just remember this fasciculata is the lighter stain, and it's a lot thicker. Yeah, here's a good image of it, this cartoon diagram. So you can see that the fasciculata is a lot thicker if you're trying to identify it. And then once you get into the medulla, you're talking about the chromaffin cells, which again come from neural crest derivation. Okay, here's the histo slide. So you can see the reticularis is here. Glomerulosa, yeah, is here. And the fasciculata is the thicker, lighter staining area. So again, this is a good histology slide to commit to memory. All right. So another disease, this pheochromocytoma, is actually is a cancer or tumor of the chromaffin cells. So you can imagine if you have hypersecretion of norepinephrine and epinephrine, you're going to get a lot of sympathetic type symptoms. So you're going to get palpitations, sweating, stuff like that. It happens, it's an episodic period. So the patient will come in and say, like, I get these really bad maybe 10-minute spans of palpitation, sweating, anxiety type stuff. But for right now, one of the important things you want to remember is vanillomalilic acid, vallomalilic acid, something like that. VMA is secreted in the urine, and that is a byproduct of the catecholamines, norepinephrine and epinephrine. But I have another slide to explain that in a second. I just wanted to put this in for clarity. So when we talk about the pineal gland, it actually develops what's called the brain sand, or the corpora araceata, and it just, from my understanding, it doesn't really cause any problems. It just develops with age. So in case they give you something like this, or they talk about the pineal gland, these spots here are this brain sand. All right, then we could break down into the thyroid gland. So it's really histologically, it kind of stands out. You have these follicles that are surrounded by parafollicular cells, and these follicles is where the thyroid hormone is going to be made. And these parafollicular cells are going to have can make calcitonin, which actually aren't super important in adults. The PTH, calcitonin is primarily to counteract PTH. So if, but it's primarily used in the fetus. But we're gonna dive into that when we get to the thyroid lecture. This is all just a little bit of intro. And you can see here the colloid is what is on the inside of the thyroid gland, and the parafollicular cells are what surround it. Again, those are going to be your C cells that secrete calcitonin. Yeah, sorry, these yellow cells are the parafollicular cells, and these are the follicular cells that are around it. Okay, sorry about that. Okay, right, and like I said, this calcitonin is going to lower blood calcium, whereas the PTH is going to increase blood calcium. Again, PTH is much more important and as an adult than the actual calcitonin is to counteract it. So this is a classic presentation of Graves' disease. When you think of the thyroid gland, think of metabolism. So if you're hyperthyroid, your you have a hyper or heightened metabolism, right? So these patients are going to be skinny, they're going to have palpitations. One of the classic presentations is Graves' disease, where you get these autoimmune antibodies against thyroid stimulating hormone. And one of the classic presentations is exophthalmos, and that's when the eyes are bulging out. There's a lot of hypertrophy behind the eyes, and it causes the eyes to swell like that. But that's very specific for the antibodies. So if you see this presentation, they're referring to Graves' disease. So again, but if you keep them in two separate categories, hyperthyroid is going to be increased metabolism, whereas hypothyroid is more of a decreased metabolism. So these patients may be overweight, sluggish, stuff like that. But again, we'll get there when we get to the thyroid lecture. So we kind of mentioned PTH at the parathyroid gland. It's going to increase your calcium levels. The idea is for PTH, it will pull calcium off the bones, but hopefully you don't have to. Hopefully you get the calcium for diet and everything using vitamin C. But if PTH needs to, it will pull it off the bones. But primarily, PTH will be able to titrate it through your kidneys. It will be able to pull more calcium or less calcium through the renal system as need be. And obviously, with calcium goes, you bring calcium back in, and you secrete phosphate in that kidney with PTH. When we get to the pancreas, the endocrine pancreas, so the pancreas is both endocrine and exocrine. Right now, we're just going to worry about the endocrine pancreas. So it's going to deal with insulin and glucagon and somatostatin, but we will get there when we get to that lecture. So these are very specific for the pancreas. These are the islets of Langerhans, and they're going to have the primary cells. So you don't need to worry about the F cells. The beta cells are going to be insulin secreting. So you see this with diabetes, difficulties with insulin secretion, or insulin resistance in type 2 diabetes. And then the alpha cells, the glucagon is going to kind of counteract it. So you secrete insulin when you just eat a meal postprandial, and you want to store or decrease your blood glucose. And if for whatever reason you're hypoglycemic, you can secrete glucagon to help increase your glucose. And then these are two different forms. We're going to talk about both of these in a little bit. But diabetes is kind of like water loving, right? So you tend to drink a lot of water because you don't have ADH. So you're peeing out a lot of water. So you tend to drink a lot of water. Diabetes mellitus is the classic diabetes, and it's sugar loving, right? Because they have increased sugar levels. So this is diabetes. You're going to hit this really hard in the DM lectures or DM block. So we'll talk about the different forms of diabetes insipidus in a second. All right, so this was this slide from first aid, something I would look at the morning of, like just to make sure I have this straight, because Dr. Chilapilla, she, I'm pretty sure on all of her lectures, she put a few slides on the secondary messenger system, right? So this is a good way to remember it. What I did was I tried to isolate it here of what you may need to know, probably, likely. And so remember, GS is going to use the CAMP secondary messenger. GQ is going to use IP3. Excuse me. So my kind of trick, I just kind of remember GOAT, right, which were these. And if it wasn't that, it fell under CAMP unless it was prolactin. But whatever works for you. But these are the primary ones. But if you want the whole list, that's all here for you. Oh, actually, you know what? I make a note. I didn't add GH. It should be prolactin and GH are both tyrosine kinase. So make sure you include that one in the prolactin with prolactin. Okay, we mentioned this. There will be a question on it. So you can see that SAD, right, supraoptic nucleus is for ADH. POX, paraventricular nucleus, is for oxytocin, made in the hypothalamus, and these neurons kind of, it travels down or courses down into the posterior pituitary here. Oh, and look, here's a good example of a test question they could ask. I think I may have a slide, but I'm gonna mention it here. If for some reason you have a lesion at the stalk, the pituitary stalk, you will get decreased levels of the hormones in the pituitary, except one in particular that you probably primarily going to want to worry about is prolactin. And the reason is if you lesion the stalk here, you can get the dopamine that inhibits prolactin, which is a classic thing you need to keep in mind. It can't actually get to the cells that secrete prolactin. So if the dopamine can't get there, you're going to get hyperprolactin, hyperprolactinemia, or increased prolactin secretion. So keep that in mind. That definitely could be a test question, but I'll try to point it out again on a different slide. All right, again here you see that the neurons go, or the axons go from the hypothalamus to the posterior pituitary to store those hormones there. Now, when you talk about hormone secretion, the primarily means there are many possibilities that could help or increase or decrease the hormone secretion, but by all means, the negative feedback system is the most important. Okay, so the downstream, whatever you have downstream, they'll feed back to the hypothalamus to help inhibit secretion. So what we'll see going forward is that a lot of the problems with the disease states is that there's a problem with the negative feedback system or whatnot. But again, we'll point that out in a little bit. Okay, so you maybe wouldn't think that this is important just by looking at it, but I seem to remember they had a test question about this. So keep these together, the ones that are on the outside of the cell and the ones that are towards the middle. And that's just because they can ask you something like if one of the cell types is affected by mechanical lesion, what is the other one affected? I think I remember a question similar to that on the test. I kind of felt it was off-putting, but just try to keep those together. Keep the gonadotropes and somatotropes together on the outside, and towards the middle, the corticotropes and thyrotropes, and then the lactotropes are kind of scattered amongst them. One of the topics that I don't think was very, wasn't pointed out very well in our term was these tropic hormones. So tropic basically means that the hormone is going to signal to another endocrine gland. So you have to ask yourself, is this hormone being secreted, going to a gland that's also going to secrete something into the bloodstream? So something like FSH and LH, eventually you get testosterone or estrogen. So you would count those. ACTH primarily is going to secrete cortisol. So you would count that. And TSH is going to secrete the thyroid hormones. So as it works out, the basophils, or the B flat, if you want to remember it, are going to be the tropic hormones. All the other hormones that are secreted are going to have a direct effect on that organ, not necessarily secrete additional hormones. Right, and I just put this here for clarification. Remember that the basophils are going to be your tropic hormones. Okay, one of those weird things, somatostatin inhibits the secretion of GH, right? So it's a GH inhibitory hormone, so keep that in mind. There is a somatostatin in the brain, along with one in the pancreas, but I don't think that's terribly important right now, just in case you come across that is the case. Okay, I put this in from first aid. It gives a little bit of information specifically on growth hormone, but what you'll see, hold on, it's coming up. Growth hormone does have this pulsatile secretion. So if for some reason you have a constant secretion, say a tumor or whatnot, it can actually affect it. The body wants it to be in this pulsatile fashion, especially during puberty or times of growth. This is what I wanted to point out. So you need to separate growth hormone. First of all, you want to put growth hormone in the idea that you're growing, right? You're trying to spawn the body for growth, right? So during puberty and whatnot, or childhood in general. So it has insulin-like effects and anti-insulin effects. But overall, the whole principle is that you want to promote growth. So things that insulin would do is to help with cartilage formation or protein synthesis. But when you talk about anti-insulin, that's where you're going to break down fat or increase blood sugar. So when you think about insulin, it's primarily going to want to store fat and decrease your blood glucose. But remember, growth hormone is going to have IGF effects and anti-insulin effects. The overall principle here is that you want to promote growth. So you want to build proteins, but you also want to break down fats to where you can get more energy for growth. So make sure you keep those separate. Okay, and again, IGF also works as both a positive and negative feedback system, whether it's increased or decreased. But you can see here that GHRH coming from the hypothalamus is going to stimulate the anterior pituitary to secrete more growth hormone, whereas somatostatin will decrease it. But just make sure you know that insulin-like growth factor also is a feedback mechanism to the hypothalamus. Okay, this is a super important, okay, I put a box around it. This is a super important point I wanted to make, is that in children that are hypothyroid, so right, when you think hypothyroid, you're thinking a slowed metabolism. So these kids might be overweight, but they're also going to be, their stature is going to be stunted. They're going to be shorter. And so if they talk about this, some child is in 10th percentile of their height or 5th percentile. So you're saying, the question would try to be implying that they're short. They could actually be hypothyroid because it has this permissive action on growth hormone. So keep that in mind. I remember a question similar to that. Okay, and then the opposite is true also. If you have this hypersecretion of GH, some terminology you want to keep in mind. Gigantism is increased GH secretion during childhood, and then acromegaly is in adults, right? So if it happens before the growth plates close, it would be considered gigantism for kids, right? Okay, now this is from first aid. We're gonna look at, I think this was Dr. Sobring's lecture. Primarily, we're just gonna focus on these top two, but these are little pathways that you definitely wanna commit to memory. You need to know all the cofactors, and I have a slide with the enzymes as well. Oh, here it is. Right, so make sure you know all the enzymes, like I said, and all the cofactors that go with these hydroxylase reactions. If you see a hydroxylase, usually TBH is going to be, tetrahydrobiopterin is going to be the cofactor for hydroxylase reactions. So keep that in mind. You can see that vitamin B6 is with the decarboxylase. And then again, a hydroxylase reaction, but it uses vitamin C here. And then SAM is a 1-carbon methyltransferase. So you're trying to move 1 carbon. And then PNMT is super important, but we'll get to that in a little bit. But remember that converting norepinephrine to epinephrine, the enzyme here is PNMT. What we'll see is cortisol actually feeds into this and helps to upregulate this to convert it. But we'll do that in a little bit. You're going to get into Parkinson's in a lot more detail towards the end of the term, but since it was in the slides, I just wanted to mention it. So this is a neurodegenerative disorder of dopamine in the substantia nigra. These patients, as I'm sure you're familiar with, elderly patients, they have what's referred to as a resting tremor. So when they're just still, they kind of shake a little bit, but it actually does increase to loss of memory, mood disturbances, and stuff like that. But I just wanted to briefly mention that here. Now, what we talked about when we discussed pheochromocytoma, remember that when you break down these catecholamines, you're eventually going to get VMA, right? So if they ever talk about a patient that comes in and they have VMA in their urine, you want to, or increased VMA in their urine, you want to think pheochromocytoma. I have another slide because dopamine actually breaks down to HVA. So remember the catecholamines, epinephrine and norepinephrine. Our VMA, dopamine is HVA. And then, yeah, we'll get to that in a second. Right, so like we mentioned, pheochromocytoma, tumor in the adrenal gland of the chromaffin cells. So you get this hypertensive episodes, headache, sweating, tachycardia are these symptoms. Right, okay, here's that slide I was talking about. So dopamine actually breaks down to HVA. But remember, with pheochromocytoma, because the tumors are the chromaffin cells, you're not going to expect to see HVA, right? You don't make dopamine with the chromaffin cells. It's just the norepinephrine and epinephrine. But I just wanted to put this in here because it is a catecholamine, and you do break it down into HVA. And it is degraded. All the catecholamines, epinephrine, norepinephrine, and dopamine are broken down by both monoamine oxidase and the COMT enzymes. I put this here Don't get confused with serotonin. It's not technically a catecholamine, and it's only broken down by the monoamine oxidase. So keep that one separate from the from the catecholamines. All right, so this is the second of the two pathways that Dr. Sobring wanted to break down. So when we take tryptophan as the primary precursor, we could break it down into serotonin, and then the byproduct in the urine is 5-HIAA. And like I said, is broken down only by monoamine oxidase. And you'll see that serotonin actually forms melatonin as well. So you want to keep in mind tryptophan to serotonin to melatonin. And then carcinoid syndrome, these APUD cells in the gastrointestinal tract, you can get this increased serotonin secretion. So what would you expect in the urine? The 5-HIAA, which is broken down by the monoamine oxidase, right? That would imply that there are increased serotonin in the body. Okay, like I mentioned, you could take serotonin and then form melatonin from it. As you're probably familiar, melatonin is important in the circadian rhythm cycle. It is secreted at night, so you can sleep well. You could actually take this over the counter. Sometimes people get disturbing dreams. It helps to shut down your frontal lobe, so you sleep better. But yeah, you'll get into that more in neuro. Okay, I mentioned that tetrahydrobiopterin is related to those hydroxylase reactions. Yeah, and so yeah, but you can actually have a deficiency in childhood. You can have mental impairment and seizures. Not terribly important, but it was in the lecture, so I wanted to go ahead and include it. We're going to break down the thyroid, the process of making thyroid hormone in a little bit, but this was actually from Dr. Sobring's lecture. I liked the slides from the thyroid lecture better than these, so we'll use those to look at the breakdown. But it kind of goes like this. You do this iodination and then this deiodination. Primarily this 5' deiodinase is going to convert the T4 to the more active T3 hormone. But like I said, we'll get to that in a second. All right, and just because this is Dr. Sobring's and it's related to genetics, remember thyroid hormone is lipophilic. So it's going to cross the membrane, it's going to go to the nucleus, and it's going to primarily act by increasing DNA synthesis in the nucleus. So it acts very similar to the steroid hormone synthesis or also vitamin D. All right, one of the misconceptions is this goiter. You might think, well, I could understand you can get a goiter from maybe hyperthyroidism, right? Because this overactivity, but you actually can find these goiters in hypothyroidism. And it's kind of similar with hyperthyroidism. There's overstimulation making thyroid hormone, but with hypo, you're getting overstimulation by TSH. So don't get confused. If the goiter formation, it doesn't necessarily mean it's hyperthyroid. It could be hypothyroid. So don't use that as something to definitively answer a question. You could find those in both. So one of the problems with, or one of the requirements of thyroid hormone is iodine. So with iodine deficiency, like I mentioned, you're going to get increased TSH secretion. Why is that? Well, because if you don't have iodine, you can't make thyroid hormone. And if your thyroid hormone is low, the TSH is going to be elevated, right? TSH is going to try to tell the thyroid to make more thyroid hormone, but it simply can't because it doesn't have the iodine. So we don't have this in the States. The salt we use is required, it's required to have iodine. So we don't see that here. Now, if you do have a maternal iodine deficiency, you can end up with congenital hypothyroidism. Again, it's not really a problem in the States, but you can see here. Again, remember that these kids that are hypothyroid, because thyroid hormone has a permissive action on growth hormone, they will have short stature. Okay, we mentioned Graves' disease, exophthalmos. Again, you have this swelling, periorbital swelling behind the eyes, and that's why their eyes kind of poke out like that. But again, that's just the most common form of hypothyroidism. Remember, it has this antibody that mimics TSH. I did want to point this out because I looked it up. Your notes say that with Graves' disease, you actually have a normal TSH. But I looked it up, and because you would think with this syndrome, if you're making this, you have this artificial TSH that's secreting a lot of thyroid hormone, you would assume that the TSH is low. And I looked it up, and it does say that the TSH is supposed to be low, but your notes say normal. So if that's confusing, maybe you can email the teacher, but the internet, which is always right, says that TSH should be low. So I don't know. All right, steroid hormones. I know this was a big stressful lecture, but as for the congenital adrenal hyperplasias, there's a really easy trick to know these. So remember that the steroid hormones are all from cholesterol. That's how you make them. So the cholesterol is shuttled into the mitochondria, and from that point, you actually break it down. Okay, so the ones we're going to talk about first are the ones in the adrenal cortex, and then we'll move on to the androgens and estrogens. We kind of beat this over the head now. Remember, the glomerulosa up top, the fasciculata is thicker. The reticularis, this isn't really a good depiction. The reticularis should be a lot smaller than that. And then the adrenal medulla down here. So remember, salt, sweet, sex toward the inside. All right, not super high yield, but I just wanted to go ahead and add it. So remember, ACTH primarily is going to act on cortisol. So once ACTH tags the receptor, it's a GS receptor, so you're going to use CAMP. It's going to take this cholesterol globule, and this star protein. It's like steroid acute receptor, something like that. You have to look it up. The star.
It's hold on. Steroidogenic acute regulatory protein.
There you go. Thank you, Lindsay. Right. So if they ask anything about the shuttling or the process of bringing cholesterol into the mitochondria so that you can actually break it down into these steroid hormones, this star protein is going to be the regulatory step. Okay. We discussed this at length during renal, but remember, if the body notices or detects that you're hypotensive, right, you're hypovolemic, you have decreased volume, your blood pressure is low, it's going to release renin. Renin's going to activate angiotensin, which will tense down on the vessels, therefore increasing your blood pressure. But it's also going to activate aldosterone. And aldosterone, if you remember, is going to pull sodium back into the body. And with sodium goes water. So by that process, you're bringing up the volume. Now, consequently, when you bring sodium back into the body, you have to kick out potassium, okay? So that's the normal process, but we'll look at some of the deficiencies in a little bit. But of course, you have to understand the normal before you understand the abnormal. Cortisols, it's one of those confusing ones. It's not, at least for me, it's not like intuitive, you know, like what cortisol does. It kind of seems like it's all over the place. So I try to isolate it. When you think about the liver and what it does in the liver and does in the adipose tissue, the overall goal, and actually the skeletal muscle too, the overall goal is to increase blood glucose. So what you'll see in people with like Cushing's disease or Cushing's syndrome, they have hyperglycemia. So they're prone to getting diabetes, right? But in line with that, or not really in line with that, it also has an anti-inflammatory effect. So you'll see with people that have hypercortisolism, whatever the reason they may have it, but if they do have it, they're prone to infections as well. Okay, so we'll break those down, the disease states in a second. I wanted to include this. Make sure you know that aromatase and know the CYP19, same thing. But make sure you know that either way, because they could put it as either one on the test. And it breaks down DHA or the precursor androgens into estrogen, okay? And they did point out that 17-beta hydroxysteroid, DH3, that's in Leydig cells, and that's going to help convert androstenedione to testosterone. So just keep these separate. I think aromatase is by far the most important. So just know either way of it, but it's important in actually forming the estrogens or estradiol. Okay. Right, so we'll talk about the congenital adrenal hyperplasias first, then we'll get into Addison's in a second. So the 3-hydroxysteroid DH is not super highly tested, at least in our term, but these other ones can be, and there's a trick to actually knowing these. We'll get to it in a second. I put a star on this. I do not like memorizing. I don't like whiteboarding or memorizing graphs or diagrams, but this is one you just have to know it, because they can ask you at any point. They could say, if you have a deficiency here, what's the enzyme, what's the precursor, what's built up, what's not being formed. So unfortunately, this is one you're just going to have to memorize. So they can even, I seem to remember on the test, they were like all blank, right? And they were like, they gave you one enzyme and they were like A, B, C, D or something like that. So anyway, enough said, just make sure you memorize this and know these different steps. Now, here's the trick. I don't know if y'all are familiar with this. This is from first aid. So let's look at the first one. So wherever there's a 1, there's going to be 2 columns. Wherever there's a 1, you're going to, this is going to be positive. Okay, so let's look at 17. So you take the 1 and the 7. So under blood pressure, you put the first one under, and the 7 under the second one. So since there's a 1 under the blood pressure column, kids with 17 hydroxylase deficiency have increased blood pressure and normal androgens, right? So it's only positive if there's a 1 there, okay? If they have 21, if the kid has 21 hydroxylase deficiency, they do not have increased blood pressure, right? Because it's not a 1, but they do have increased androgens, right? Decreased blood pressure, increased androgens. For 11, you would expect both, right? Because there's 1 in each column. Increased blood pressure, increased androgens. Now, if you were confused on the tests, I would pick 21 because that's the one that's most highly tested. That's the one that is most common. So for example, if they say a kid comes in, a 5-year-old comes in and their blood pressure's 90/60 and the female, and she's a female and has ambiguous genitalia. So you would say, well, the blood pressure's low, androgens are elevated because there's masculinization. So you would say 21. So that's a quick way of doing it. It helps me out, but yeah, that's straight out of first aid. So this is also from first aid. And you might be asking, if you break it down, why 11 beta hydroxylase has increased blood pressure, because technically you're not forming aldosterone. And that's because 11-deoxycorticosterone is a mild mineralocorticoid. So it by itself, by building up, can actually increase your blood pressure. But again, if you just remember there's a 1 in each column, you will have increased blood pressure and increased androgens. And then this is kind of a table, and you can read that here. And I really like this Sumatra's table. So if you're a table person, you can break this down here. Okay, so then we get into the sex steroids. So the hypothalamus is going to release GnRH to the anterior pituitary. You get LH, remember L for Leydig, goes to Leydig, and FSH, the F is for Sertoli. Leydig is going to make testosterone. FSH is going to help with developing sperm. You'll get into this a lot more in repro, but this is kind of an intro to it. So DHT, super important. This is a very important enzyme to remember, 5-alpha reductase. It's going to convert testosterone to the more potent form, DHT. It has a higher affinity for the androgen receptors. So that DHT is the more potent form of testosterone. 5-alpha reductase is a super important enzyme. And then in females, LH is going to go to the thecal cells to help make testosterone. It's kind of a process. You make testosterone and then you make estradiol. So the follicle stimulating cell or follicle stimulating hormone, remember follicle goes with follicle, it goes to the granulosa cell and make estradiol. Now remember that this contains aromatase, and or CYP19, and as we mentioned earlier, that's going to form estrogen or estradiol, which is the most common form of estrogen. Now let's look at Addison's disease. Yeah, okay, great. So Addison is basically you get atrophy of the adrenal gland. So if you have Addison's disease, you're not making aldosterone, you're not making cortisol, and you're not going to really be making the sex steroids. So anything that is coming from the pituitary gland to stimulate the adrenal gland is going to be elevated. So you would expect to have an elevated ACTH, like you can see here. And that's because, for instance, you can't really, you're not making cortisol. So some of the other symptoms that are very characteristic of it, they get this bronzing effect, right? And that's because when you secrete ACTH, which like I said is elevated, the precursor to ACTH is POMC. And when POMC splits, it makes ACTH and MSH. MSH is melanin secreting hormone. And when you get too much melanin, you're going to get increased pigmentation. So if you see a question on the test that talks about somebody coming in with bronze skin or increased pigmentation, light bulb should go off. They're probably talking about, at least for right now, they're probably talking about Addison's disease. So you can see here some of the other ones. And you could ask yourself, why do they have salt cravings? Well, because they don't have aldosterone, right? And if they don't have aldosterone, they're going to be peeing out a lot of water, going to be peeing out a lot of salt. So you would expect their blood pressure to be decreased, right? Hypovolemia. Okay. Now, keep these separate. However, you need to remember. Remember, Cushing's disease is a problem with the pituitary gland. Cushing's syndrome is a problem with the adrenal gland. Now, these patients, when they come in, they're going to present the same, right? They're going to have these cushingoid features, right? The moon face and hyperglycemia, maybe diabetes, probably overweight. So how do you diagnose this? And this is like a good example of a test question, because they could say this patient comes in like this and they can give you a differential and say which one, based on their ACTH, what do they have? Now, if the problem is in the pituitary, it's secondary, right? And that's because you have high ACTH. Let's do Cushing's syndrome first. When you have primary hypercortisolism, right? The primary means that the problem is in the organ that's secreting the hormone of interest. I hope that made sense. So let me use the example. The problem is with increased cortisol. So if you have primary hypercortisolism or Cushing's syndrome, the problem is in the adrenal gland because the adrenal gland is what's secreting cortisol. Okay, so that's primary. Secondary means it's not the organ of interest. It's a different organ that's signaling to the organ of interest that that the secretion, that's causing the increased secretion. So I'll say it one more time. So Cushing's syndrome is going to be a primary problem with increased cortisol, right? And that's because it's in the primary organ that secretes cortisol. Cushing's disease is a pituitary organ, pituitary problem, and it's secondary, right? So what you would expect is the high ACTH, and that's what's actually causing, that's a secondary effect that's causing the increased cortisol. Whereas Cushing's syndrome, you're gonna have low ACTH because you may have some sort of adenoma in the actual adrenal gland that's causing the increased cortisol. So it's gonna have a feedback effect on the ACTH. So it's very important you keep the primary versus secondary. Primary just basically means it's isolated to the organ that's secreting the hormone problem, the hormone of interest. Okay, so this is just like, for example, Cushing's syndrome, like I said, you could have an adrenal adenoma, it's primary, and it's causing the increased cortisol. Cushing's disease is going to be a secondary problem, and it's going to cause high ACTH. So remember, with the primary hypercortisolism or the Cushing's syndrome, you're going to have low ACTH because the increased cortisol in the adrenal gland is feeding back to the pituitary to say we don't need any more ACTH. And then this is kind of classic for them. They have these striations or striae, and then this this buffalo hump is what it's called, the moon face, and they're typically overweight. You can get hirsutism, which is facial hair growing, and increased facial hair or increased hair in general. And also remember that they're going to have high blood glucose. Okay, because cortisol has the effect of increasing your blood glucose, which predisposes them to diabetes. All right, so the hypothalamus and posterior pituitary. So you could have a problem with the entire pituitary being decreased, the hormones being decreased. So it'll be all the, so for example, Sheehan syndrome. So you wouldn't necessarily consider the pituitary gland like a watershed area where you have decreased blood flow. But as it happens, if there's increased postpartum hemorrhage, you can get decreased blood flow to the pituitary gland. You have decreased blood flow, you can have a problem secreting the hormones because because of the decreased blood flow can actually destroy the cells of the pituitary gland. Now, as you could kind of work this out, if you can't secrete the hormones, you're going to have decreased hormones overall. This was, I mentioned this earlier, this pituitary stalk problem. This is a great test question. If you have a problem with the pituitary stalk, the dopamine that's supposed to signal to the cell secrete, the lactotrophs that are secreting the prolactin, it can't access it, right? So then you're going to get hyperprolactinemia. So if they tell you the pituitary stalk is injured and they ask you what hormone is elevated, it's prolactin. And that's a good way of testing if you know that dopamine's coming from the brain to inhibit the prolactin. GH deficiency is kind of straightforward, right? You would expect dwarfism in these kids. Now, prolactin, what I wanted to point out here is obviously it helps with milk secretion, but what I wanted to point out here is prolactin has the effect of suppressing GnRH, which makes sense, right? Because you don't, when you're after pregnancy, or actually you start making prolactin during pregnancy, you just don't, it's not used, you don't actually secrete it. But the GnRH synthesis is decreased because you don't need LH and FSH. But here's a good example for you. So think about this. So if you have hypothyroidism, you're going to get increased TRH. And one of the things that's not really intuitive is that TRH actually can increase prolactin. It's a positive feedback system. So it'll or feed forward system, excuse me. So TRH will increase prolactin. So if prolactin is increased, you can get GnRH inhibition. And if you get GnRH inhibition, you can get anovulatory cycles, right? So it's kind of like this pathway that you can look at that kind of encompasses a lot of the different pathways in endocrine. So it's someone that's hypothyroidism, that's having anovulatory cycles, you can use this pathway to kind of work it out.
Brady,
okay, yeah.
So when it comes to the hyperprolactinemia, if it's like untreated or if it gets bad enough, can that lead to like uncontrolled milk letdown? Because I remember there was a question from like lecture 1 where we had to determine where there was like a pituitary injury based off of like the clue was that there was milk ejection.
Yeah, for sure. Like that would probably be a pituitary stalk injury. Yeah, okay. For sure. From the dopamine. Okay, and like I mentioned, perfect slide for it. You see that the dopamine actually inhibits prolactin. So if you secrete dopamine, you can get decreased prolactin. Now, I mentioned TRH is stimulatory to prolactin. So keep that in mind too. It's one of those off-ball things that they could ask you about to make sure you have that straight in your head. All right, prolactinomas. Remember, the pituitary sits in the sella turcica. And again, you'll get to more of this when you get to neuro, but they may ask you something like a patient has blurry vision. What it's actually called is bitemporal hemianopia. It's like you get blurred vision on the outside. But what you need to know right now is that if someone has a prolactinoma, hypersecretion, of milk or milk ejection, you can actually get blurry vision. And that's just because of the proximity of the pituitary gland to the optic chiasm, which projects the nerve fibers to the eyes. All right, and then as for the posterior pituitary, remember these hormones are synthesized in the hypothalamus, but they're stored in the posterior pituitary, the neurohypophysis. Now, diabetes insipidus, remember water loving. Why is that person always thirsty? That's because they're always peeing out a lot of water. And that the problem is with ADH here. So you can have a central diabetes insipidus, and that means you have decreased levels of ADH secretion. So you would consider this a primary problem, right? Because ADH is the main problem. Nephrogenic is increased levels of ADH, and that's because you're actually secreting a lot of ADH, but the cells in the kidney can't react to it. So if someone comes in and they're saying they're always thirsty, you check the osmolarity of their urine and it's really concentrated. It's really dilute, right? And you're asking yourself, well, what could it be? Well, it seems like they're not producing enough ADH, right? They're not bringing that water back in. They're not bringing that salt back in. You have to ask yourself, well, is it central? Is it a central ADH problem or a nephrogenic problem? And this is how you diagnose it. So what you do is you just give the person ADH, right? So if it's central, that basically means they're not making ADH. So if you give them ADH, they're going to respond to it, right? So the urine osmolarity is going to go up. They're going to start peeing out a lot more. It's going to be a lot more concentrated. They're going to start bringing a lot more fluid back. So their serum osmolarity will go down. Their urine osmolarity will go up. Is that right? I think that's right. The point is they'll start reabsorbing more water, right? They'll keep more water in. They won't be peeing out a lot of water. Now, for nephrogenic DI, even if you give them ADH, the problem isn't the actual ADH. It's the fact that the receptors won't respond to the ADH. So regardless, if you give them ADH, they won't respond to it. So their urine concentration won't change. It'll stay highly concentrated. I'm sorry, highly dilute. So let me just do this again just to make sure it's clear. So if you give a person with central DI ADH, they're going to be able to bring back more water. They're going to keep more water in their body. Their urine's going to be more concentrated. Okay. They're going to hold on to water because they can respond to the ADH, the exogenous ADH you give them. If it's nephrogenic diabetes insipidus, you're not going to respond regardless. So there'll be no change in the urine. So the urine will continue to be very dilute because they actually have increased levels of ADH in the body. It's just that the kidneys can't respond to it. Okay, so that's a good test question, differentiating central from nephrogenic DI. All right, so the opposite is possible too. You could have syndrome of inappropriate ADH. Now, what's that going to cause? That's going to cause you to hold on to a lot of water, right? You're secreting a ton of ADH, so you're going to be bringing in as much water as possible. So your serum will be very dilute, right? Your urine will be very concentrated because the ADH is going to tell your body to hold on to as much fluid as possible. So they'll probably have a lot of swelling that goes on to it, that goes in their body. And also the urine concentration will be elevated, right? Because they're holding on to so much water, their urine is going to be very concentrated. So be able to differentiate the differences between diabetes insipidus, whether it's central and nephrogenic, and syndrome of inappropriate ADH. All right, and then briefly we'll discuss oxytocin. This is going to be covered in repro more, but this helps with contraction. And so if for two examples that will stimulate oxytocin release, nursing a baby, that will help with milk ejection from the breast. And also during birth, pressure against the cervix will help to contract the uterus to help to stop the bleeding, postpartum bleeding. Okay. All right. I have put a break in here for everybody. So we'll take a 5-minute break and we'll get back. All right, let's move on. So we'll talk about the adrenal glands next. And we've seen this slide a million times, which kind of tells you it's super important. Remember, the fasciculata is going to be the thicker part, salt, sweet, sex is reticularis, and then the medulla, you're under sympathetic control. Remember that the medulla is from neural crest cells, right? They could ask you that. Now, you're probably aware that cortisol is a stress hormone, right? So if you're stressed out, whether it be an infections or psychological stress or whatever, an illness, you tend to secrete more cortisol. Cortisol is also secreted more in the morning. Guess that makes sense because I'm certainly more stressed out in the morning than I am at night. So yeah, that's that. So just remember, ACTH is going to feed forward to cortisol, and cortisol is one of those stress hormones. So you could see here, this is a good example when we talked about Addison's disease. So this POMC that's made is going to break down to ACTH and MSH. So remember, with Addison's disease, you have atrophy of the adrenal gland, right? So none of the hormones in the adrenal gland are going to be secreted. So therefore, the pituitary is going to be constantly signaling, saying, make more, and the adrenal gland just can't. So what's going to happen is that POMC is going to be constantly made because you're constantly making ACTH because the adrenal gland can't make cortisol. But all the time, the whole while you're making ACTH, you're also making MSH, which is why those patients get the bronzing of the skin. And yeah, again, the hyperpigmentation, POMC is that precursor. Okay, we talked about this already. Just remember that when you have hypotension, your body's going to notice, recognize that, and try to increase the volume. It's going to use angiotensin to squeeze down on the vessels, but it's also going to go through measures to bring more water in because you don't want to pee out a lot of water. You want to keep it. So it's going to signal the renin, angiotensin, aldosterone system. Aldosterone is going to help bring the sodium back, and water always goes with sodium. So you increase your blood volume. Conversely, if you have increased cell volume, extracellular volume or fluid, you're going to want to get rid of it. So you're going to decrease or inhibit the juxtaglomerular apparatus or the renin angiotensin system, aldosterone system. Therefore, you will pee out more water. Okay, so let's talk about hyperaldosteronism. So primary hyperaldosteronism, where's the problem? Since it's primary, that means it's coming from the adrenal gland, right? And this is referred to as Conn syndrome. Now, this is very similar to some of the other diseases that we were looking at. How do you differentiate this? And there's one distinguishing characteristic. So for this one, primary versus secondary is going to be the amount of renin that's produced. Okay, so you could see that with primary, with Conn syndrome, you're going to be secreting a lot of aldosterone, and that's going to feed back to tell the system to decrease your renin. So that is a very big differential to tell you that you have Conn syndrome or primary hyperaldosteronism. Secondary is not going to be coming from the cells that produce aldosterone. It's going to be coming from a different place, right? So here you're going to have increased renin. So a great test question is somebody comes in, they're holding on, let's say their urine's very concentrated, right? Because they're holding on to a lot of water, they're holding on to a lot of salt. Maybe they have hypokalemia, right? Because if you have hyperaldosteronism, by bringing the sodium back, you have to pee out a lot of potassium. So maybe they're hypokalemic because they're peeing out potassium. And they ask you to distinguish, do you think it's primary or secondary hyperaldosteronism? So you can do it this way. So like I said, some of the symptoms, they're going to have hypertension, either primary or secondary. You'll have hypertension, again, because you're holding on to salt, you're holding on to fluid. Hypokalemia, because the aldosterone is going to kick out the potassium into your urine. Alkalosis, if you remember downstream in the collecting tubule, one of the methods of trying to bring back this potassium is to kick out hydrogen. So if you kick out hydrogen or the acid, you can get alkalosis. And we'll distinguish it. Here's a good slide. I put a star on it because they definitely could ask you this. Decreased renin versus increased renin. Is it primary? Is it secondary? Okay, the opposite is also true. So you would accept the symptoms to be completely reversed. Hyperkalemia, you're holding on to a lot of potassium. You may be hypovolemic, right? Because you're not able to bring back the fluid with aldosterone. And then hyponatremia, why is that? Because you're not bringing back the sodium in the water, right? Decreased extracellular fluid. So it's pretty easy to remember because they're just flipped. All right, and then the adrenal medulla, as I mentioned, these chromaffin cells are neurocrest cell origin, and it's an 80-20 split for epinephrine, norepinephrine. Y'all remember the enzyme that's important from going to norepinephrine to epinephrine is PNMT, And the cofactor is SAM. SAM is a methyltransferase. It's a 1 carbon transfer. All right, now the relationship here, cortisol, this is an important point because cortisol actually has, it's more of a long-acting hormone, but it does have an effect directly on this pathway. So cortisol will actually upregulate PNMT to help convert norepinephrine to epinephrine. Not super important, but if they ask it, you can try to remember that there is this axis, the sympathetic adrenal axis that cortisol is involved with. All right, and then catecholamines, if you try to remember that this norepinephrine or epinephrine or the catecholamines are your fight or flight response. When you're running away from a bear, what do you want? You want a lot of blood glucose, right? You want everything breaking down so you can run as fast as possible, all the energy possible you can need. So if you keep that in mind, you can remember what goes into it. But basically, you're increasing your blood glucose so that you can mobilize everything so you have enough energy to run fast. All right. And so I did mention this briefly, that the catecholamines is going to be more of an immediate response to stress, which makes sense, right? You're running from a bear. You have this immediate sympathetic drive, instantaneous, whereas the cortisol is more of a prolonged effect, prolonged stress. You're going to have a delayed action. But remember, I mentioned cortisol does have that effect to act on catecholamines, to upregulate PNMT, to convert norepinephrine to epinephrine. Okay, and then again, the stress response. So right, the catecholamines, if you keep that as a short-term response, and the mineralocorticoids, increasing blood pressure. The glucocorticoids, like I said, cortisol has that longer term response. So stuff like breaking down lipids. Again, cortisol has that effect of decreasing your immune system or your immune response. But this line here is indicating that cortisol does have that effect of converting norepinephrine to epinephrine by upregulating PNMT. Keep that in mind. All right, everybody's favorite, the thyroid. So remember the thyroid, when I think of thyroid, I think of metabolism. So people that are hyperthyroid, like Graves' disease, they tend to be very skinny. They metabolize, they break down glucose a lot. They're hot. They're, sometimes they have the bulging eyes, sweaty, stuff like that. Whereas hypothyroid, their metabolism is slowed down. So they're overweight, amongst other symptoms. Okay, fatigue being one of them, or sluggish, stuff like that. All right, so from the hypothalamus, your TRH was going to stimulate the anterior pituitary to make TSH to go to the thyroid gland to make thyroid hormone. Remember, iodine is very important here to make T3 and T4. T4 is going to be your primary thyroid hormone, but T3 is more active. But we'll get into that in a second. I just want to point out, remember, TRH has that effect of upregulating prolactin as well, okay? So like I said, T4 is the primary player here, but it's converted to T3, which is the more active form. So it's kind of more, it's more stable in the T4 form, but once you get to T3, it's more active. And we'll get into that in a second. I don't want you to get too bogged down with this, but just remember the stepwise process. So from the blood, you're going to bring in iodide, which is the charged form with a sodium symporter. You're going to increase your iodide. The thyroglobulin is more of the storage form. And then the iodide is going to come across. You're going to oxidize it. And then you're going to iodinate, increasing the, or adding the iodine to it. And then thyroid peroxidase is going to be the enzyme here, the main player. And then once that's done, you're going to conjugate it to MIT and DIT. 2 DITs goes with T4, a DIT and two DITs and an MIT is T3. I don't know. The thing about this is it's not, it's hard to write questions. Like this gets a little complicated. And if you think about it, they really focus on clinical aspects. So don't get too bogged down with this process. It's kind of difficult to write questions regarding this when you think of it in a clinical aspect. But just in case you were interested, I went ahead and put this from first aid, so you could see it here. Now, like I mentioned, the point of the thyroid gland is to increase metabolism, so the increased basal metabolic rate. So by doing that, this is a good thing from first aid. You can see the B's here, breaking down or increasing blood sugar, right? So increased basal metabolic rate, bone growth, brain maturation. So you can remember these if it helps you to remember things that increase metabolism. This was a little interesting. This was highlighted, so I felt like I should put it in. Remember, T3 is the more active form. Even though you're breaking things down, you're metabolizing stuff a lot, it does have the effect of increasing protein synthesis. So it's one of those things that stands out. It could be testable just because it's kind of like, it's like a red flag on the slide. So just keep that in mind. But as for this all kind of goes with this first aid slide. Remember the B's, this kind of all goes together. Yeah, so remember, it does have an anabolic effect of building proteins, whereas everything else is kind of breaking things down because you're just burning through sugar. Excuse me. Super important enzyme here, 5-deiodinase. That's what's going to convert T4 to T3. So that's definitely testable. You want to remember this enzyme here. All right, so then clinical applications. We did mention Graves' disease. So we're thinking hypothyroidism. Hashimoto's thyroiditis is another one that they taught. I don't know that they really talked about it too much. Graves' disease is the main one, the main player here. And then you could get increased iodine in your diet or radioactive iodine, but I don't think that's super testable. Excuse me. The main thing you want to remember is Graves' disease. So again, we're talking about increased metabolism here, right? Hyperthyroidism, irritability, weight loss. It can cause amenorrhea, palpitations, heat intolerance. Anything when you keep in mind, the metabolic rate's going to go up. All right, and then again, Graves' disease, the most common cause of hyperthyroidism. It does tend to happen in females more often. So remember the pathway. It does make this autoantibody that is similar to TSH. Again, I'll mention this again. Your notes do say that the TSH is normal, but online it says it's decreased. So I don't know what you want to do with that. And then some of the signs, again, we mentioned this, the it's called exophthalmos. It's called the bulging of the eyes, ophthalmopathy. There you go. And then they do get this pretibial myxedema, which is sort of like a non-pinning edema, typically in the lower limbs. But be careful with that because you can get this in hypothyroidism too. So don't use that as a direct correlation. But yeah, these are caused by these autoantibodies.
Oh, I just had a
Thyroid,
question.
yeah, sure.
Oh, hey, thanks so much for doing this. I just had a question
No
really quick
worries.
with pretibial myxedema. I think Dr. Chilapilla said that the pretibial is in the Graves' disease, but then there's an all over edema in the hypothyroidism.
Yeah,
So,
yeah,
like
it's like
this one is just specific to that area, and then like the hypothyroidism, it's like edema everywhere.
it's more like a swelling. Is
It's a
that
swelling,
how she
like
refer? Yeah,
a global
okay.
swelling.
Yeah, I think the terminology might get confusing because it is technically a myxedema. I guess maybe it's not pretibial, it's just like this swelling effect that they get. Yeah, you just need to be careful on the test that you don't just directly correlate this with one or the other. But yeah, thank you.
Yeah, and actually, Brady, they did have a question, and I remember edema was on there for hypothyroidism, and I paid special attention because I have it, and that wasn't the answer. So I don't think it's like edema everywhere. I think it's maybe like,
Okay.
I don't know, like maybe that's what I guess I got confused with that too, because that was one of the answer choices that I was like, wait, is that it or not?
I see what you're saying. Yeah, so just be careful with that. It's not necessarily diagnostic for one or the other, but maybe it'd be good to just research it a little bit and see if there's any differentiating characteristics of the myxedema that can translate to one or the other. But ideally on the test, I imagine they'll give you other clues that are more apparent than this for either of those. Thank y'all. And then this can actually lead to thyroid storm, which is like this overblown thyroid response, this increased palpitations to the point where you have to go to the hospital. So it is problematic. And then again, this is increased sympathetic response, but think about metabolism when you're looking at. Now, hypothyroidism, Hashimoto's thyroiditis is one of those. If you get a thyroid removal, that's one. And then iodine deficiency, of course, if you can't make thyroid hormones. So remember, these people are going to have a decreased metabolism. They're always going to be fatigued. They may be overweight, may have a low blood glucose. But this is going to be caused by typically, again, we want to differentiate primary from secondary, but secondary would make sense because it's coming from the pituitary, right? Primary is going to be a direct problem with the thyroid gland. So again, differentiating the two is important. So we could see here it is. Yeah, so look, you could see the mixed edema is also due to hypothyroidism. Again, yeah, so it's like puffiness. Yeah, you get this like this swelling effect. So maybe we wouldn't classify this as pretibial mixed edema. This is just mixed edema, so they may just end up really puffy. Again, fatigue, cold intolerance, weight gain, menstrual problems. This kind of all correlates with this decreased metabolic effect. All right, now we're not going to dive into this too deep. I really feel like any questions they ask you about this are going to be pretty basic, just because DM is going to dive into this like times 1,000. So they're going to keep this pretty basic. So I'm going to try to just talk about the stuff that is really testable. So insulin actually has 2 chains of insulin, plus it has a C-peptide. The C-peptide is important because that's what we use diagnostically to check and see if you're making the insulin in your body versus if you're taking it exogenously. So I think there's a slide coming up that someone mentioned the sulfonylureas and stuff. So we'll get to that in a second. But just remember, so it comes out the insulin from the pancreas in this tripeptide formation. And once the insulin's cleaved into the alpha and beta chains, you get this C-peptide. It doesn't really do anything in the body. It's just measurable. So once it's free, you can check to see. So if someone has an insulinoma, they're producing a ton of insulin, their C-peptide are going to be up. But if somebody's injecting insulin, it obviously doesn't have a C-peptide. It's just like exogenous insulin. They're not going to have any C-peptide. So it's a good diagnostic clue if you see somebody passed out because they took too much insulin or whatnot. But there's a table coming up and I'll show y'all. Okay, good, right? Well, here, we'll talk about it here. Again, the endogenous insulin, you're going to expect to have a high C-peptide, high insulin levels. Don't really worry about the proinsulin, but the C-peptide definitely has a longer half-life, so you can measure it to see what's going on. So remember, insulin is going to be secreted after a meal. The whole goal of insulin is to decrease your blood glucose. This is why people that have diabetes that don't make insulin have elevated blood glucose. They could show up to the hospital with, glucose levels of 500, 600, sometimes more than that. So the problem is they don't have insulin. So after you eat a meal, your blood glucose is elevated, the insulin's going to be secreted, and it's going to take that blood glucose and it's going to pull it away from the blood and put it into your muscles, your liver, whatnot. Remember that GLUT4 is super important because it's insulin dependent. You need GLUT4 to bring the insulin into skeletal muscles and stuff. So it's like a switch. And again, we'll get to this more in when we get to DM, but it's just a switch. You're either insulin, you're trying to decrease your blood glucose, or glucagon, you're trying to increase it, right? They work completely opposite. So as for the endocrine pancreas, we touched on this with these islets of Langerhans. The beta cells are going to be what secrete insulin, and the alpha cells secrete glucagon. So if you've just eaten a meal, you're going to secrete insulin. If for some reason you're hypoglycemic or fasting, you're going to secrete glucagon. Glucagon is going to help to increase your blood glucose by glycogenolysis or gluconeogenesis, right? So gluconeogenesis, making new glucose. Glycogenolysis is the storage form of glucose. So you break down glycogen and you make it as well. But again, we're just going to touch on this stuff. Delta cells release somatostatin. I did mention, excuse me, that somatostatin is made in the brain and here. So this is, it's going to actually inhibit insulin and glucagon. It has an effect of allowing the stomach to, I like to say like it lets the food kind of like sit in the juices or the acid. So you're not going to secrete insulin or glucagon. You're going to let everything break down first. But that's more of a DM problem. So don't worry too much about that. As long as you know that the somatostatin is related to the delta cells, you should be fine. All right, so regulation wise, you know, this isn't super high yield. I just felt like maybe it'd be good to just kind of memorize these amino acids. So primarily, anytime you eat or the body recognizes an elevated blood glucose, you're going to secrete insulin from the beta cells, major activator, right? So something above 90. But they do have some smaller activators such as arginine, leucine, and glutamine. But I don't want to dive too much into it. I just think maybe if you just remember these, just in case they give you a multiple choice question that relates to those, you'll be good to go. And inhibitory are going to be, like we mentioned, somatostatin, which will inhibit both from those delta cells. And then epinephrine and norepinephrine is inhibitory because obviously if you're running from a bear, you want elevated blood glucose, right? You don't want to be worrying about storing it. You want to use it. So epinephrine and norepinephrine, we're going to put that on the glucagon side of the table, right? Insulin's the storage, glucagon's the mobilization, right? So we want epinephrine and norepinephrine on the glucagon side. All right, so again, we want to mention GLUT4 here. Remember, that's the one that is insulin dependent, okay? So whenever you use these GLUT4, whenever you have insulin, you can use GLUT4 transporters to bring in glucose into the muscle. Okay, yeah, and this, I just put this, again, the GLUT4 in the muscles, but liver, you're gonna wanna store everything, bring the glucose in. It uses GLUT2, yeah, 2 there, and then fat cells. Again, you're gonna wanna be storing these tags, storing fat with glucose. And then for the brain, glucose is the primary source. You always wanna have glucose for the brain, which makes sense, because if not, you have to use ketones, but y'all will do that later, so don't stress it. All right, now glucagon's the opposite. If you're fasting or you have a low blood glucose, you can release glucagon and it's gonna mobilize any stores of glucose, okay? So it's gonna mobilize the stores, it's gonna make new glucose, it's gonna break down glycogen, okay? Basically put, that's all you really need to focus on now. And these should be the opposite, right? So the primary activator of glucagon is going to be low blood glucose, right? It wants to bring up your blood glucose. And just in case they ask you a silly question, just commit these amino acids to memory as a secondary response. So you would expect these inhibitory things to be on the insulin side of the table, right? So insulin or increased blood glucose would counteract the glucagon, right? Because that's the storage form here. Okay, oh yeah, so Dr. Trotz did make a point she said this a couple of times, I remember that these glucagon receptors are found in hepatocytes and renal cortex cells. So make sure you know that you could find glucagon receptors in both places. Now, it may be important to know the different timelines for this. So if you postprandial, you're going to release a lot of glucose, right? So you're going to help to store any or decrease your blood glucose and store any additional glucose. Post-absorptive, this is about the 8-hour part. That's when your blood glucose levels tend to decline. It's time to eat again, or maybe you have an overnight fast. And then starvation, it's the 3-day point, and then you're going to start breaking down. At this point, you've really used all your glycogen. You're starting to make new glucose from gluconeogenesis, and you may enter ketogenesis. Okay, and then you know, a lot of the numbers are given to you on the test, but these are good to know. Your fasting blood glucose should stay between 70 and 110. If you eat a meal 2 hours later, it should be less than 120. And then anything lower than 55 is considered severe hypoglycemia. So these measurements are different measurements clinically to diagnose diabetes, right? So you can use these, there are different methods of doing it. You can also use the hemoglobin H1C, which is more of a 3-month measurement of it. But you can use any of these clinically to diagnose it. So I would commit these numbers to memory. All right, let's see. Yeah, so some of the cells that are strictly dependent on glucose, such as the red blood cells, they are dependent on it. The brain, the retina are examples of cells that are, or areas that are specifically dependent on glucose, right? Anaerobic glycolysis is predominant in the red blood cells. So just keep that in mind. Oh yeah, so remember that the primary mechanisms of balancing your glucose levels are going to be insulin and glucagon. But, but if you're, so this is just a regulatory process, okay? So this is going to keep you in balance. But you can use glucagon, epinephrine, cortisol, and growth hormones, but these are more of a preventative measure, okay? So when you're getting down to that 55 level where you're severely, where you're like symptomatically hypoglycemic, these are preventative measures, okay? So these can be released to help with gluconeogenesis, just kind of stimulating it if you're getting too low. So, but remember, primarily, ideally, you just want to just measuring your insulin and glucagon levels and keeping yourself balanced. But if for whatever reason you haven't eaten in a while or whatnot, you can get some additional stimulus here to prevent too low of hypoglycemia. Yeah, again, it's more of the same, right? So these can be released, so commit these to memory. But again, these are just to prevent that extreme hypoglycemia. Ideally, you want to stay with just the insulin and glucagon. So if you get lower than 55, which is kind of that cutoff, you're starting to get severely symptomatic. You can get adrenergic or neuroglycopenic symptoms. Now I put them here. Yeah, so if it's an abrupt fall, this adrenergic symptoms can kick in with epinephrine release. This is not as bad as neuroglycopenic. You can see these symptoms are more of anxiety, palpitation, sweating. Neuroglycopenic is more of a gradual decline in glucose, right? Getting below 40. So if we say 55 is a strong cutoff to be symptomatic, if you get below 40, you're starting to deprive the brain, right? You're going into ketogenesis, and you know, that's not ideal. It's not an ideal situation. So then you can get some more of the neurologic symptoms here, slurred speech, even a coma. Okay, so one of the important things is nobody likes to drink, eat a meal before they go to the bar, because it's easier to get drunk if you haven't eaten in a while, right? That's not my advice, but you know, it is what it is. So the thing about alcohol is that it leads to this increase in ADH, NAD ratio. And again, you get more into this in DM, but by doing this, this ratio, it helps, it causes the hepatocytes to reduce gluconeogenesis. So if you're already in a state of if you're already in a state of fasting when you drink alcohol, the ethanol can prevent you from making new glucose. So you can get this fasting hypoglycemia, right? So again, this is caused after a long fast, then you drink, and then the alcohol will inhibit you from making new glucose. Okay, insulinoma. So like I mentioned before, if you have an insulinoma, if you're secreting a lot of endogenous insulin, you're going to, from the beta cells, you're going to have an increased C-peptide. So that's a good measure if you know, it's a good measure clinically to know if it's endogenous secretion. So if you get this, you would expect someone to have severely low hypoglycemia, right? And that is because the insulin, the whole goal of insulin is to decrease your blood glucose. So if you're secreting too much of it, you're going to have very low insulin levels. Here's that slide. So a lot of times the question they'll ask, they'll tell you it's a nurse because they have access to insulin, IV insulin, and they'll say they find a nurse passed out on the floor in the bathroom or something, and you took blood levels and you were trying to determine if it was an endogenous problem with insulin or if he or she is injecting insulin. So the way to tell is if you're injecting insulin, obviously you're not going to have C-peptide, right? Because that's only formed in the body. If you're taking it from a vial, this is just normal insulin. There's no C-peptide involved. So if it's high here, proinsulin, yeah, present. If your C-peptide is high, it's from endogenous insulin. So sulfonylureas is a medication that you can give to diabetic patients. And so this causes an increase of endogenous insulin. So you would expect the C-peptide to be high, right? So exogenous, endogenous, and some of these correlate similarly, right? So even though you get increased levels of insulin, the C-peptide will be low because it's exogenous. So it's an easy test question. All right, I think this is the last one. We'll talk about calcium. Y'all learned about vitamin D in term 1, so this is a lot of the same. So primarily, all of the calcium stores are stored in the bone. Ideally with PTH, you're not gonna have to dive into the bone to eat off a bunch of calcium to bring it into the blood. But if for some reason you have hypocalcemia, you can mobilize it from the bone. But ideally, the PTH will be released to kind of titrate it in the kidney. So you can just modulate it there. Of the calcium, the small amount of calcium that's actually in the blood, the ionized form is what you're going to be, what you want to remember. Remember that the ionized form is physiologically active. So keep that in mind in case there's a test question about that. So 3 routes you can increase your blood calcium. With vitamin D primarily, you can increase the absorption of calcium along with phosphate in the gut. You can mobilize it with PTH from the bone. That's not ideal. You don't want to break down your bones if you don't have to. And PTH acts on the kidney. Right? In the kidney, it'll increase calcium, but it'll cause decreased phosphate or phosphate secretion or excretion. So keep these 3 in mind. Remember, PTH and vitamin D work together to help regulate your calcium levels. All right, and again, phosphate, it typically goes, when you pull it off the bone, it's calcium phosphate, so it's going to increase, but it's important that PTH work in the kidney because it will allow you to bring calcium back into the body, all the while decreasing your phosphate level. Phosphate's not super important, it just kind of tags along with calcium along the process, right? So it's just one of those things you have to keep in mind. The main thing to remember is that in the kidney is where they kind of split. You can bring your calcium back into the blood and you can pee out the phosphate. All right, now PTH, like we mentioned, it's going to regulate your calcium. It's going to be your most effective way of increasing your calcium. Like I said, you primarily want to do that in the kidney. You don't want to pull it off the bone if you don't have to. So PTH will work in the distal convoluted tubule to help bring back calcium and get rid of phosphate. All right, so again, ionized calcium in the blood is the active form. So if it's decreased, it's going to cause the increase of parathyroid gland, and you're going to increase PTH, and that'll tell the kidney to bring back more calcium. And like I said before, it'll increase calcium levels in the kidney and decrease phosphate levels. If it does have to act on the bone, it'll bring back both. So in the bone, PTH will increase calcium and phosphate because it pulls out off calcium phosphate. But the main goal here is to only use it in the kidney where it will increase calcium all the while getting rid of phosphate. That's the goal. And y'all know by now, calcitriol is the active form of vitamin D. So you make sure you know this. So we go through the process. We have 7-dehydrocholesterol. UV light will activate it until to cholecalciferol. You can also get that through the diet. Remember, 25-hydroxylase is located in the liver. So if you have liver problems or liver disease or cirrhosis, and you don't have access to this enzyme, you can get elevated of cholecalciferol just because you can't make this. But the main test question they ask are for people with kidney failure. In the kidney, you have 1-hydroxylase. And if you have kidney failure and you don't have access or enough 1-hydroxylase, you can't convert 25 vitamin D to 125 vitamin D. And 125 vitamin D is the active form. So they'll tell you somebody comes in with renal failure, and they also have hypocalcemia. So what's the problem? They don't have 1-hydroxylase to make the active form of vitamin D. One of the important things, very similar to the steroid hormones and thyroid hormone, vitamin D works in the nucleus, right? So it's lipophilic, goes through the membranes, goes straight to the DNA, and helps to increase gene expression. And that'll help with the formation of proteins, primarily calbindin, right? So, and this will work in the stomach, in the duodenum. So you bring, vitamin D will help to synthesize calbindin in the nucleus of the cells. So calbindin will be increased, and that will help to bind the calcium in duodenal cells. And then you can bring increased calcium into the bloodstream, right? So that's, and again, oh, sorry. Again, phosphate will go with it, right? But primarily remember that vitamin D has the effect of increasing calbindin to bind the calcium in the gut to bring it back. Calcitonin, not terribly important, simply because it doesn't really play a huge role in adults. It works in it works in the fetus and neonates, but in adults we really don't use it. You know, PTH can help primarily regulate the calcium homeostasis. Now, when we look at hyperparathyroidism, what would you expect? Well, you would expect elevated levels of calcium, right? And phosphates, and phosphate in the urine. So if someone has this, you would expect the PTH to be acting on the kidneys, causing an increased calcium and decreasing your phosphate. So a lot of phosphates in the urine. So just one of those key words here, you can see a shortened QT interval. That's on the EKG. The space between the Q and T is shortened, and that's indicative of hyperparathyroidism. It's a good mnemonic for it: stones, bones, abdominal groans. I think like psychiatric overtones is another one. You can get psychiatric symptoms here. But kidney stones, bone pain, abdominal pain, that's all correlated with hyperparathyroidism. Now, primary hyperparathyroidism means it's primary, so it's happening in the parathyroid gland, right? That's the problem, and it's going to cause PTH to be excreted in elevated amounts, primary. Secondary hyperparathyroidism means the problem's coming from somewhere other than the parathyroid gland. So problems could be diet deficient in vitamin D. If you don't have vitamin D, you're not bringing in the calcium into the body. So that's going to cause the parathyroid gland to start secreting PTH, right? So primarily when we talk about the secondary hyperparathyroidism, we're talking about a problem with vitamin D. Also, you obviously have a need for increased calcium during pregnancy and lactation for the baby. So again, if you're looking at some lab values, you would expect increased serum PTH and a low to normal serum calcium, or decrease urine calcium, because the PTH is bringing it back in. But what you want to look for here in secondary hyperparathyroidism typically is, what is the vitamin D level, right? So if you have a low vitamin D, that could be indicative that you have secondary hyperparathyroidism. So rickets is vitamin D deficiency in kids, vitamin D deficiency in adults is osteomalacia. Classically with rickets, you get the bowing of the legs. So you're going to get decreased levels, if you check the lab values, decreased levels of calcium and phosphate, just because you're not absorbing it in the gut. That's that's due to vitamin D deficiency. And then you can get a primary hypoparathyroidism. Primary means it's a problem with the parathyroid gland. If for some reason when you get a thyroidectomy, well, you know, the parathyroid glands are kind of located on it. So it's very easy to have those removed during surgery. But what would you expect if you can't secrete PTH? You're going to get a low calcium. You may get a high phosphate, because remember, in the kidney, it's the PTH job to pee out all the phosphate. And conversely, you're going to get a prolonged QT interval. This will probably be like a side note in the question, like you can answer it without this information. But if you see that, it's kind of, you can put a check mark. You're like, yeah, that's definitely hyperparathyroidism. So that's just the QT interval is on the EKG. So features of hypocalcemia. So it has to do, if y'all remember, the action potential, or the, you know, with so it's basically going to decrease the membrane potential, so that the membrane excitability is going to be increased. So you're more likely to fire action potentials. So if that's the case with hypocalcemia, you would expect a lot of contraction, right? So if you decrease this or increase the membrane excitability or decrease the threshold, which is saying the same thing, if you decrease that threshold, you're going to get a lot of action potentials firing. So you can get this tetany, patients will be locked up. You can get this, I'm gonna butcher this, Chevetsky sign, right, where you tap on the cheek and you get this facial nerve, this twitching due to the facial nerve. And Trousseau's sign is kind of when you put a blood pressure cuff and you squeeze it really tight and they kind of lock up. So again, you get this prolonged QT interval. But remember, hypocalcemia will increase the membrane excitability or decrease that threshold. So you get increased firing. And that's it. All right. So you could find everything on Scrubs. That's not it, actually. Lindsey's going to do questions with y'all now, because that's what y'all want to do. And y'all could find everything on Scrubs. And if y'all want to snap, y'all all have access to the Google Drive by now. But I will hand it over to Lindsey, and y'all can do some questions now.
This is perfect timing. I just logged back on to Zoom.
Oh, you weren't listening to me, Lindsey?
Well, my computer was slowing down.
Sure it was.
I just really was getting tired of listening to you.
I don't like listening to me, so I don't know.
No, and then it like automatically started updating too. It was like, oh no, okay. So, oh no, why is it? Oh, my computer just doesn't like Zoom right now, I don't think. But we will persevere, guys. I think I just need to turn it off and let it just like chill for an entire day.
Yeah, do that.
Okay. Okay. So I am going to put up slides of questions, and you can private message Brady or I with your answers. Don't put it in the chat to everyone so that everyone gets a chance to think through it. And we will go over these questions. Okay. The questions are not currently in my drive, but they will be after this session. We wanted you guys to be able to answer these without having the answers in front of you, because I know we usually, okay, why are you not cooperating with me today? The answers are usually right in front of you. And so we wanted to make sure that you got the chance to answer these on your own. Why isn't this cooperating with me? It's not, why can't I find how to share it? Present.
We could see it. Oh, there you go. Yeah.
Okay. So this is your first question. Remember, private message myself or Brady with your answer. Okay, I'm getting a lot of people for D, and that is the correct answer. And the reason it's correct, the correct answer, and Brady just went over this, you have low C peptide levels and absent proinsulin. If this was normal insulin made by your pancreatic beta cells, you would have these things. And so since they are absent, you know that he injected his wife's insulin. It doesn't give us any history, but that doesn't matter because we have the lab values. And so whatever led to him injecting himself with his wife's insulin, it doesn't matter. We have the lab values, and that's a confirmatory diagnosis. Okay, it's kind of all over the board right now. I like this. Okay. Okay, we have about every single answer choice being represented right now. Okay, so let's go through this since there's not really a consensus. There is one answer choice that's getting a little more action.
HA is headache.
Yeah, headache. I apologize, guys. So a tumor is impinging on the supraoptic nucleus in the hypothalamus. So what hormone is responsible? ADH. Exactly, ADH. So which one of these symptoms is directly related to ADH if we have the hormonal imbalance? It's going to be polyuria. So the answer is A. For those that are putting hypertension, hypertension is going, if you don't have ADH, you're not getting reabsorption of water back into your system. So you're actually peeing a lot. And if you're peeing a lot, you're actually going to lean more towards the hypotensive scale instead of hypertension. Does that make sense?
Lindsey, so when you say the tumor impinge on it, so it's defecting it, like it's not making enough.
Correct.
Okay. Thank you.
Correct.
And
Yeah.
why? No.
Yeah. So remember, ADH and oxytocin are not made in the posterior pituitary. It's in the hypothalamus, and it's transferred from the hypothalamus to the posterior pituitary where it's going to be stored and released. So if you're impinging that area, think of a physical block. You're kind of closing it off. And so you're making ADH, but that doesn't mean you can get it into the pituitary to actually get it out into the system. So that's why you're going to have low ADH. And because of that, you are not reabsorbing water. And so you are peeing it off. And that's polyuria. Increased urination is polyuria. So are we good with that? Any last questions? Okay, I'm going to go on. Okay, we have a nice spread of answers, but there is a consensus, and the consensus is correct. It is going to be anterior pituitary. Why are we focusing on anterior pituitary here?
Is it because that's where growth hormone is released from?
So the two big symptoms are enlarged head, feet, and hands, which is growth hormone, and then gynecomastia and lactation, which is prolactin. Both of those are in the anterior pituitary. And so since we're getting multiple symptoms from the anterior pituitary, we can safely say that the anterior pituitary is where the problem is. And so you could add multiple other anterior pituitary symptoms and it's still going to be the same. So that is why we are focusing on anterior pituitary. And any questions before we move on?
Couldn't this also come from like an issue with the hypothalamus causing increase in growth hormone releasing hormone?
It could.
Because that I was like, I wasn't sure which one it is because both of them could cause this.
Right.
I think it's one of those best answer things,
yeah,
right?
Best
So if you take
answers,
all the symptoms together, it looks like it's a lesion of the anterior pituitary.
Because also dopamine is going to be the inhibitor of prolactin. So if we have increased prolactin, you can fact check me where dopamine is actually made, because I know it from NB. But if the hypothalamus, if there's an issue in the hypothalamus, I don't know if that would.
It's up in the brain, yeah.
Yeah,
like the
basal
nucleus accumbens.
ganglia. Basal ganglia is going to be the dopamine. So to your point, if we only showed the growth hormone effects, you could go back and forth between hypothalamus and anterior pituitary, but because we also have prolactin, that's increased prolactin, so you're getting the basal ganglia, that's the dopamine, and so it's specifically in the anterior pituitary. I think I just went around in circles, but that's why.
I think I have a question. Like
Mhm.
the professor mentioned, like if you have high growth hormone,
Mhm.
something, I guess because it's similar in structure to prolactin,
Mhm.
you can have also hyperprolactinemia, and not
Mhm.
necessarily related to the hyperlactin, but not the other way around. So if you have a hyperlactin, you will have growth hormone symptoms.
Yeah, that's
Will
true.
that make sense?
Yeah,
Yeah.
that's absolutely true. Yes.
Okay. Thanks.
Okay, next one. I did pull this one from pretest because I thought it was a really good question. So if any of you guys have pretest, I went through their questions and some of them I thought were really, really good for you guys. So I didn't change anything about this question. Okay, we have a consensus. Well, we have a couple more sprinkled in through there, but we do have a consensus on B, and that is correct. So this is pretty high yield. So what we want to know is how iodine are stored, what form iodine is stored in, because you only get the synthesis and release if you get the receptor binding from TSH. So it's stored as thyroglobulin. And if you can get that, that should be an easy point on your test.
And don't get tripped up when you see that the child is short and think it's necessarily a growth hormone problem, right? Remember kids that have hypothyroidism, because it's a permissive action on GH, they can end up being short as well.
Yeah, I'll give you guys a little more.
Sorry, that protruding or that fat tongue is classic for hypothyroidism too, if y'all see that.
Okay, I accidentally didn't put a normal question on here, but I'm gonna let you guys read it. This is yes, I'm gonna give you guys a little more time. I apologize about that. But I want you guys to read this question. This is another one straight from pretest. I think it's really important for you guys to understand this, but I gave you guys the answer. If you have any questions, please let us know. Okay, are there any questions on this one? Okay, this is also another easy question if you can get this. Okay, so I have 72 seconds on my timer, guys.
Oh, I'm sorry. Can you explain why that was unbound for thyroxine?
Yeah, so if you have a bound protein, it is not free to react. Does that make sense?
Yes.
So if it's bound to a plasma protein, it's not going to be able to react with any of, with a receptor. So that's why unbound is going to be more active. Exactly.
That's one of the big purposes of plasma proteins, is to actually carry different molecules to their target organ, and then they're unbound. If they were just floating around unbound, they would act in different areas that they don't want to, that they're not supposed to be. So
Yeah.
you need it to be unbound to be active. And one of the things that you'll see is like people that have liver problems or cirrhosis, they're not able to make these plasma proteins. So they're not able to properly carry around these molecules or these particles around to where they need to be. So that causes long-term problems.
Okay, so I'm gonna put 72 seconds back on my timer. Oh. We're getting a pretty decent spread here. Think about, we're saying most rapidly, most rapidly. Okay, you have about 5 seconds left. Okay. It is actually bone. Stop it. So this is going to be the most rapid system. It's not A or B because this is going to take a little bit of time, because in the intestine, you actually have to do the calbindins and you have to get the receptor going. Kidney, you also is going to take a little bit of time. Bone, remember, this is going to be your biggest reservoir of calcium when you need it. And so if you have a condition that causes chronic hypocalcemia, you can actually get osteoporosis, because the bone is going to be used to replete that the serum calcium levels.
You could think about it like this. So when in the intestine, you're primarily thinking vitamin D, first of all, but you have to actually ingest more calcium to absorb it, right? Also in the kidneys, you're just kind of titrating the levels that are coming through your blood. Whereas in the bone, you can literally just eat chunks off and pull it into the body, because 99% of the calcium is there. So it may not seem intuitive, but just remember where those stores are, like Lindsey mentioned.
Okay, any questions before we go through that? There was a lot of there wasn't agreement on that one. It was kind of fun to watch, but yeah. Okay. Indirectly.
I do have a question. So isn't the bone supposed to be the last place where you want to?
I mean, you definitely do not want to continually take from bone, because that can be detrimental. But if we're talking about a rapid correction of calcium, then bone is going to be the most rapid direct action of PTH.
Okay.
Is it because there's already low serum calcium? So if the kidney were to even try to, there would be not enough supply, and same thing with the intestines.
That's exactly right. The point is that this patient is diagnostically hypoparathyroid, right? So by being that you have clinically relevant low calcium. Okay, so the only source is the last resort, which is the greatest stores of it. It's the most rapid, but yes, it is the last resort. But you have to have blood calcium to regulate so many body systems.
Yeah. So to reiterate, in testing, you actually have to ingest calcium. So this is more for like chronic hypocalcemia levels to over time get it to where you want to be. Kidney, like Brady said, is going to titrate what is already there. But since we have clinically low levels, the bone is going to be the most rapid direct action because this is your stores. This is just a reservoir in your body if you need to increase serum calcium. Okay, we will move on to the next question. Again, HA is headache, BSG is just blood sugar. ED is just emergency. Sure. Okay, good. We have a general consensus here. There are a few outliers, but okay. You do need to know all of these just so you guys are aware. You have about 8 more seconds on the timer. I was a scribe. Okay, well, you got it right. It's pancreatic beta cells. I guess I changed it on my answer slide and not on the question slide, but it also is important that you know where these cells are located. Again, this doesn't change the answer. It's still pancreatic beta cells, but you do need to know if they are located centrally, and then the alpha cells are located more at the periphery of the islets of Langerhans. And so alpha cells, what do they secrete?
Glucagon?
Glucagon. What about on my previous slide, it said delta cells. What do delta cells secrete?
Somatostatin.
Yeah.
Somatostatin.
So it's really important that you guys know that. It can be easy questions on the exam for you. Again, I didn't change this on my question slide and I apologize for that. I will do it when I release it. But you do need to know where the different cells in the islets are located. Phoebe! Aww. Sweet girl.
Yeah, sorry. She was aggravating me.
Okay, next question. SX is symptoms. Yes, I did.
This is a mean question. All that
I know.
It's like step
yes.
2? Jeez.
I thought that instead of doing like a handful of hypo versus hyperthyroidism, I would just do one question and see if you could get them all.
Yeah, that's good.
Might as well train harder, right?
Yeah.
A lot of these are pretty intuitive when you think about them. Like when you sit down and you actually make a chart of hypo and hyper side by side, it actually becomes pretty intuitive. Some of these aren't as intuitive, so you just have to memorize them. Yes, that is supposed to be palpitations. Even when I was a scribe, I would have to be really careful when I did that word because it would mess me up. Okay. So we have B, E, F, and I. So let's go through these one by one. Heat intolerance is going to be hyper, and cold intolerance is hypo. And so make sure that heat and cold were always two that would confuse me. I don't have a very good way of remembering that. Brady, do you have a good way of remembering
I
heat
like
versus
if
cold?
you think like increased metabolism, you're kind of hot, right? It's like you're working
Yeah.
out all the time. It's like, but if you're decreased metabolism, it's very cold. You're not doing a lot of work.
Okay, I like that. That does make sense. That is pretty intuitive. Okay, coarse brittle hair, yes. If you have hyperthyroidism, you're going to have thin, fine hair. Pretibial myxedema, this is a under the hyper column. This is something, again, that we said was under Graves, which is hyperthyroidism. And so that is going to be hyper. Diarrhea, so think about hyper as anything heightened. It's anything high. And so diarrhea is going to be overactivation of the GI system. And so if you have overactivation, if you're moving contents through your GI system, you're not having adequate passage of water and materials, and so you have diarrhea. It's just going through your system. Whereas constipation, hypo, you have low GI motility, and so you're pretty backed up. So increased bowel movements versus decrease. Lethargy, hypo, you have decreased energy. Tachycardia and palpitations, because I can't spell. These are all like increased cardiac, whereas hypo would be bradycardia. Weight gain versus weight loss. You have weight loss because increased metabolic rate. This would be a decrease. And then diaphoresis is going to be hyper. And then decreased or lack of sweating would be more hypo. So make sure that I have a lot of people putting really good stuff in the chat. I hope this is to everybody. I don't know. But yeah, make sure that you know this because there will be a handful of questions on the exam. If you get it down real good, they're easy points. But if you start getting tripped up, it can lose a few points on the exam. So there's a really good chart in first aid that you guys can go through. This is another one that I took straight from pre-test. I thought it was a really good question for you guys. Okay, we're getting some answer choices coming in. About 10 more seconds. Okay, so the answer is C. So first, when you're talking about hormones, what are you seeing with Addison's disease?
Decreased cortisol?
Decreased adrenal hormones?
Yeah, so it's going to be all adrenal hormones. And so the question is testing your knowledge of this, but then it wants you to translate this into, okay, so now that you know it's all of them are decreased, what does that look like in lab values? So does somebody want to talk about the different lab values and how this relates to the hormones?
So you should have decreased aldosterone, which would cause the increased potassium and decreased sodium.
Mm-hmm.
You would also, with the decreased aldosterone, you'd also end up having a decreased blood pressure because you'd have less water conservation, so you'd have decreased blood volume.
Yeah.
And I think the blood glucose is because you wouldn't be producing cortisol, so you wouldn't be producing your catecholamines, and you'd have incredibly high, not high, but you wouldn't be able to turn off your insulin, basically.
Yeah. Awesome.
That'd be secondary, but remember that cortisol has a
Yeah.
direct effect of increasing your blood glucose. But yes, that's a good point.
Okay, any questions on this? Okay, let's go to the next one. I have 21 questions for you, I believe. You have 10 more seconds. Okay, most of you got it right. It is hypertension. So first off, Conn's disease or Conn's syndrome. What are we looking at here?
Hyperaldosteronism, primary.
Primary hyperaldosteronism. So because it's primary, what does that tell us?
That the problem is at the actual gland or organ.
Exactly. The problem is in the actual organ. Now, aldosterone, what is that going to be responsible for?
Blood pressure and salt, so mostly sodium.
So if we have a primary hyperaldosteronism, it is going to lead to hypertension.
What are the potassium values?
Would potassium be low because it's the opposite every time?
Yep.
Yeah.
Exactly.
What about, here's a bonus point. What about the hydrogen? What happens to it?
Oh yeah, that's a good one.
Alkalotic. You're going to be metabolic alkalosis.
Alkalosis, right? Yeah, because by trying to bring in the potassium at the very end of the tubule, you'll be kicking out hydrogen ions. So you would get metabolic alkalosis. That's that weird, oh shoot, what was it called? The paradoxical aciduria thing.
Yeah.
Yeah, it's weird. Yeah.
Okay, it looks like everyone's pretty good with that.
Oh, okay. So sorry. So Brady, were you saying that like with alkalosis, because if K is low, then like hydrogen follows that?
So the potassium, you're going to put it in the urine, and then as it goes down the tubule, the body's going to say, we want to take back, you're still going to pee out a lot of potassium, but you're going to try a last ditch effort to bring it back in, a little bit of it. And by doing that, you're kicking out hydrogen ions. So a lot of the acids, you're going to pee acid out. So it's just like a last ditch effort to try to grab as much potassium as you can from the urine. And by doing that, you have to sacrifice hydrogen.
Okay, so hydrogen stays in the urine.
Yeah, right. So you get an alkalosis. Yep.
Okay, perfect.
Okay. Next question. Some of you guys are falling into the trap. Make sure you read it very carefully. So if you are picking more than one answer, ask yourself why you think it's more than one. Some of you guys are kind of split. Read the question very carefully. Okay. Insulin independent versus insulin dependent. You need to understand that because different GLUT transporters are going to react differently. Or some GLUT transporters, you do need the presence of insulin. Some GLUT transporters, you don't. So our answer is actually the brain. So insulin dependent is going to be adipose and skeletal muscle. You need insulin, and then that is going to do the GLUT4s, and then that is going to do insulin dependent uptake of the blood sugar. But if GLUT1s for the brain are insulin independent, and that's super important because the brain always needs a constant source of blood sugar. And so even in the absence of insulin, the brain can use up blood sugar because it's in the hierarchy of what needs metabolism. The brain is at the very top of this hierarchy. And so it does not need the presence of insulin to get the GLUT transporters in it. So I kind of alluded to it, but what GLUT transporters are responsible for each of these?
For the brain, it's GLUT1, right?
Mm-hmm.
And then GLUT2 would be the one that's independent, right? So that would be like the pancreas and the liver.
Yep.
Yeah,
that's right.
And then, yeah, skeletal and adipose are both GLUT4, and GLUT4 are insulin dependent. Yeah. Okay. Moving on.
Lindsey, sorry. Wouldn't cardiac also be independent? Or am I like,
I'm going to look that up for you.
Because like for some reason, like I remember when I was post reading that it was always like, this is the reason why people who are diabetic don't like, pass out.
Okay, it says GLUT4 is the insulin regulated glucose transporter, and it includes striated muscle, which is skeletal and cardiac.
Yeah, I was just checking back through my notes. So GLUT4, they're all your insulin dependence, and it's fat, heart, skeletal.
Thank you for confirming that, guys. Okay, I'm going to give you guys a little more time on this one just because we've kind of been talking about the previous question. So I'm going to actually reset my clock so you guys, and this also takes kind of a lot of reading too. We have a nice split between about 2 and 3 answer choices. Okay, So I'm going to give you the answer and we're going to talk about it real quick. So first, this is a really good process of elimination question. So first off, we are talking about insulin release. So insulin release, where are we talking about insulin release? Pancreas, right? And so what glutes are we talking about in the pancreas? What transporter? GLUT2. So we're going to eliminate anything that says GLUT4. And so you are left with B, C, or E. Now we have to look at the next. So intracellular ATP. So all of our answer choices say intracellular ATP. Now we look at the next one. It says blocks potassium channels. And so there are two that says blocks and one that says opens. So we know it's blocks. So we're going to eliminate answer choice E. So now we're going between B and C. And the difference between the two is calcium increase versus calcium decrease. And if we are depolarizing the cell, we are getting an increase in calcium. And this increase in calcium facilitates the exocytosis of insulin. So this is a really good process of elimination. Are there any questions from this?
I think Lindsey makes a really good point. Like, that's exactly how I do it on the test. And like, once I get to a point where I'm like, okay, that part's wrong, I cross it out, like physically on ExamSoft, strike it out so I don't have to look at it again, right? So do it like that and find where the little differences are and decide between the two and then cross them out. Because psychologically, it makes it a lot easier when they're like physically crossed out. So use it to your advantage.
So I had a question, when would GLUT4 be the answer? GLUT4 would not be the answer. And the reason being, we're talking about insulin release, and insulin release is at the level of the pancreas, and the pancreatic cells have GLUT2 transporters. GLUT4s are in adipose and muscle. So that's where you would get GLUT4. So we're talking about insulin release. So that's the pancreas. And then I have another question about the potassium channels. Yes, you just have to memorize that it blocks it. It is conceptual. I mean, if you think about it this way. You have an increase of ATP. So think about it as ATP being a lot of people in the room. And so if you have more people in the room, the exit is going to be blocked, right? And so all of these ATP molecules, you can kind of think about it as it's blocking those channels. There's a more like biomolecular way of putting that, but just as kind of a cutesy little analogy for you, you can remember it like that. And then because you're getting the blocking of the channels, then you have the depolarization because you're not getting the movement, that depolarization, and then the cascade that eventually leads to exocytosis.
I think I didn't put this in my slides, but I think there was literally a slide in your lectures that explained this. It had like a cell and it had like different quadrants that had like where the potassium was being blocked and the calcium was entering. And it was like a stepwise process. So I would go look for that.
This is extremely high yield though. You will probably have a question or two on the exam in some form or fashion testing these concepts. So I would definitely look over that. But if there are no questions, I will move on to the next. Dang it, this was a really good question. Okay, hopefully you guys didn't see the answer choice, but you can, this was such a good question. Or is such a good question. Okay, good. Some of you guys didn't see my little mishap there where I showed you the answer. So just go ahead and answer it and we'll talk about it because Brady gave you guys a really good way to remember this, but sometimes the vignette is not as nice as the trick. FYI. And I fell for this when I first did this question, so that's why I wanted to put it on here, because it's not, there's a point in here that's not obvious unless you're paying attention. And I don't want you to make the same mistake I did in practice questions. Okay, so there are two popular answer choices right now. I like it. Okay. So I want to go through Brady's trick real quick. So a 1 means what?
High.
High. And so if we look here, lab shows severe hypernatremia. What could you also say about this patient if they had hypernatremia? High blood pressure. Yes, there you go. So what does that mean? If we're using Brady's trick, what does that mean in the enzyme? The first number of the enzyme.
It should have a 1.
It should have a 1. Then further testing reveals high androgen levels. What does that mean about the second number of the enzyme?
It should have a 1.
It should have a 1. So our answer is 11 beta hydroxylase.
Let me ask you this. If you have increased androgens, in a male or female, would that be more evident phenotypically? Which one?
Female.
Female.
Right, because increased androgens is masculinization. So if you do have that increased androgens, typically it'll be a female presentation that has ambiguous genitalia. And the converse is true if you have decreased androgens. The male will get decreased masculinization. So keep that in mind, because if you have increased androgens in a male child, it may not be as evident as it would be with a female.
Mm-hmm. Any questions on that? I can't hear you.
Can you hear me now?
Yes, I can hear you.
Can you go over this question again with the trick that you were talking about?
Of course. So we said that if the enzyme
Hey,
has
Lindsey,
yeah.
Draw it out. Maybe you could draw it out on the little side.
Where's my stylus? Here's my stylus. Oh, sorry guys. I don't know if it's gonna let me because it's on one of my external monitors. It's not on my touch screen. Can you do it, Brady? Can you annotate it? You're muted.
Yeah, sure. So the first column is increased blood pressure. The second column, androgens. There you go. Close enough, right? All right. So the goal here is to determine these. And if it's increased, then we're going to put a 1 in that column. So hypernatremia goes with aldosterone, right? Remember, wherever salt goes, water's going to go. Okay, so hypernatremia is going to cause increased blood pressure because of the increased aldosterone, right? Because anywhere salt goes, water goes. So this is an indirect way of saying that the child has high blood pressure. Okay, so we're going to put a 1 in this column. Now it says directly you have high androgens. So does it say if it doesn't say if it's a male or female, but it says directly high androgens. So we're going to put a 1 in this column. So since you have a 1 in both columns, you know it's 11. Does that make sense?
I was confused on this one because it says severe hypernatremia. So I thought that would be like really high blood pressure, like really high. And then in the slide, it said mild hypertension.
Well, I mean, it depends on the severity of the aldosterone increase. I mean, they likely have high, really high blood pressure and high hypernatremia. I mean, I would say I wouldn't get bogged down with that. If they say you have high blood pressure or hypernatremia or you're hypervolemic, then always go with the increased blood pressure column. I wouldn't get caught up in the milder or severe. Yeah.
Especially with what it's asking you to distinguish some of these, it's going to be high versus low. And so simply because this is high, you are going with our trick, you're going to look for an enzyme that begins with 1. And then with the additional information of the androgen levels with our trick, you can determine which enzyme. So mild and severe here, it's not as diagnostic. There are some diseases that you'll get into, especially with DM, that distinguisher is very important, but here, not so much.
I was requested just to point this out. So increased androgens basically correlates to increased testosterone. And increased testosterone means you're going to get masculinization. So for a neonatal female, that masculinization could result in ambiguous genitalia. For a male that has increased androgens, it might not be as evident, okay? Whereas if you have decreased androgens, then the male's not getting the testosterone he needs, so therefore he may end up with ambiguous genitalia. So just keep that in mind phenotypically. If there's increased masculinization, that's going to affect the female more. And one thing to point out here with the 11 is that even though you're not actually making aldosterone, the 11-deoxycorticosterone, the precursor to it, is a mild mineralocorticoid. I think that might have been what you're referring to, Kelly. I think it was Kelly that asked the question about like the mild mineralocorticoid. So for 11, maybe you could probably estimate that the blood pressure might not be as high in someone with a like say 17 or whatnot, just because the deoxycorticosterone is a mild mineralocorticoid opposed to the actual aldosterone. But I wouldn't get caught up in a lot of the details. If you know this trick, you should be able to answer these questions.
And just to know, I wrote this question, and so I put severe to kind of highlight the fact that there was hypernatremia to make sure you guys trained your eyes to it. And so this is a student-made question, but my intention was to highlight the fact that this patient does have hypernatremia. In a physician-written question, they might not have put severe; they would have probably put mild, but the points, I mean, I'll correct this if this is going to be something that confuses you, but the point stands that we are talking about an increase in blood pressure and an increase in androgen levels. But thank you for pointing that out. Okay.
I can clear this. Okay.
Okay. Next question. Yeah, good. There's a general consensus here. This is a really important enzyme. I'm pretty sure they stressed it in the lecture that you really need to know this. You have about 20 more seconds. I'm going to go ahead and show the answer. So every single one of you got this right. So if you see this on an exam, hopefully it's easy points for you guys.
I'll let y'all answer, but then we'll do it for this too.
So this one isn't one where they're asking you to, well, they're asking you to diagnose the patient, but they want you to take it one step further. Do you know the characteristics of your diagnosis? Okay. So before I give the answer, let's diagnose this patient with the enzyme deficiency. So blood pressure of 90/58, would you call this hyper or hypotension? Yeah, hypo. And then,
sorry. It is, so you should know that this is present in all the CAA, all the congenital adrenal hyperplasias. You're going to get decreased cortisol. That's just how it works out. So that's not going to be diagnostic for you.
Yeah. And so we don't have something that says androgen levels, but we do have a phrase in here that shows you what we're talking about with respect to puberty. So the first sentence, it says, the mother is concerned that he is developing at a much faster rate. What is this called? There's a term for this.
Is it precocious puberty?
Precocious puberty. And so precocious puberty, if you're going into puberty early, what do you think that means for your androgens?
They're pretty high.
Yes, they're pretty high. So you have a low blood pressure, which means you do not have a 1 in this position, and you have a high androgen level, which means you do. So we're talking about 21 hydroxylase. So now we've diagnosed the patient. Now we have to remember some, now we have to remember characteristics of this diagnosis. And this, I don't have a fun way to remember this. I just remembered it. Brady, do you have a fun way to remember?
What am I remembering? I can't remember.
The characteristics of each diagnosis.
I was drawing smiley faces. No, you could go ahead.
So so the answer is increased 12-hydroxyprogesterone, which is, it points it out to you in first aid, but decreased sex hormones is not going to be correct, because since we know they have precocious puberty, it's an increase in androgen. So B is not correct. Decreased renin activity, this is not going to be incorrect. It's actually increased renin activity for 21 hydroxylase deficiency. Does somebody know the basis behind this?
So I'll just, if you have decreased aldosterone, right? What's the signal that's going to try to tell it, right? It's going to try to tell you to increase your aldosterone, but it's not going to be able to. So this is actually going to be elevated. This is what I was saying, like, this is what I was saying, is one of the things, sadly, you have to just draw out the chart, draw out the steroid hormone pathways. Oh yeah, it is 17.
Yeah, sorry guys, that was a typo on my part. I'll fix it when I send it out to you.
Yeah, so you just have to memorize the chart, because they can ask you infinite number of questions about, this is a perfect example, like you just have to know what's the precursors and what's the downstream deficiencies. So,
and we're not going, and we already know this because of the trick, but for D, hypernatremia, why are we not going to have hypernatremia?
Because there's no aldosterone being made.
Right, exactly.
Right.
Yep. Cool, good.
Okay, so I'm going to correct this when I go back. I apologize for that. But yeah, that's how you do it. I hope you all get this question right. There are 21 questions in total. I don't know how many, I don't know what number we're on. But these will be posted later. So if you absolutely need to go, I will not be offended. Questions and answers will be posted later.
And the recording.
Yeah, and the recording. Okay, 3, 2, 1. All of you are getting that correct. I am so glad. They stress this a lot in the slides. So make sure to read the question, because our question on the exam was not this straightforward. So just make sure you're reading the question very carefully.
Remember that in the adrenal medulla is like that weird thing where the preganglionic fiber goes literally all the way to the chromatin cells, and then the chromatin cells are this modified postganglionic structure.
Yeah.
Right, so it's preganglionic though, right?
The cells are postganglionic.
The pre goes to it, and then the cells.
Yeah.
It's just wording.
Got it.
So for example, B, if it says they synapse with preganglionic sympathetic, then that could have been an answer as well.
And there's cells, right? D says
yeah.
Sympathetic cells, not in the fiber.
Yeah. Okay. Okay, we kind of have a split, but we're getting a lot of good. Yeah, most of us are getting the right answer, so that's good. So remember the difference between primary and secondary. Okay, let's work through this and then I'll give you guys the answer. So our TSH levels are high, and also our T3, so that's thyroid hormone. These are high. Now, let's look at A. Graves' disease is hyper or hypothyroidism?
Hyper.
Hyper. So we know that this is going to have increased T3, but this is at the level of the receptor, right? And so if we have high T3, what's going to happen to our TSH if this is at the level of the thyroid?
The TSH
would be low.
Yeah, it's going to be low or normal. Your slides say normal, but low to normal because of negative feedback, right? So we're going to cross this out. Hashimoto's, is this hyper or hypo?
Hypo.
Hypo. So we're going to cross this out. Pituitary adenoma. What would pituitary adenoma cause? So this isn't at the level of the thyroid, right? This is at the level of the pituitary. So this would cause increased TSH. I'm getting that. So increased TSH. Increased TSH then causes increased thyroid hormone because we're stimulating the thyroid. But we have hyperthyroidism. But is this primary or is this secondary? Secondary. Because this is not at the level of the actual organ. So this is a contender. Sheehan syndrome. What's Sheehan syndrome?
It's when you've got like a global not atrophy, but like a global loss of your pituitary gland, and so all your hormones are not working.
Yeah, panhypopituitarism. Yeah, this is going to be due to a dramatic decrease or dramatic loss of blood status post labor and delivery. And so that can cause kind of a watershed effect in the pituitary. And then so you get that panhypopituitarism, correct. Primary hyperthyroidism, if it's primary.
Oh, sorry. Just an interesting point about that. Sometimes they diagnose that because the women can't. They end up not being able to lactate. That's one of the diagnostic features. They realize it soon after when the mother tries to feed, and you can diagnose that.
Yeah. Primary hyperthyroidism. So hyperthyroidism we know is increased thyroid hormone, but if it's at the level of the thyroid, what do you think is going to happen to the TSH?
It'll be low.
It is going to be low because of negative feedback. And then hypothyroidism, we already know this is incorrect. So the answer is going to be your pituitary adenoma. So again, we said this in term 1, make sure you know why the incorrect answers are incorrect and why the correct answer is correct. So primary and secondary kind of messed me up. It took me a while to get that in my head, but just make sure you understand what happens if it's primary versus secondary.
This is just a question about the Sheehan syndrome again, because Brady just alluded to the fact that you don't have prolactin with that also. So I'm just trying to make a distinction between that and then like that other thing where that one condition where I think the stalk is broken or something, and then you will have increased prolactin.
Yes.
Like all the other ones won't work, but then with Sheehan, it's like everything doesn't work. So even prolactin.
Everything's down. Right.
Yeah,
exactly.
and the reason that is because Sheehan's is at the level of the pituitary, and the pituitary is the one synthesizing and releasing the prolactin, whereas the stalk is going to block dopamine. And remember, dopamine is a tonic inhibitor of prolactin. So if we're not inhibiting prolactin, that means that we can't that you're going to have an increase versus, again, the Sheehan, which is the destruction of the area. So even if you don't have dopamine, it doesn't matter. You can't make prolactin. Does that make sense?
Yes, it does. Thanks so much.
Cool. Yeah. Oh, come on. There we go. Okay. So we are looking at Parkinson's. What causes this?
Decreased dopamine.
Decreased dopamine. Yeah, decreased dopamine. And so if you don't have dopamine, you're not going to have its metabolic product, right? What is its metabolic product? HVA. So we can cross out this increase in dopamine, that's the opposite. So we know it's going to be decrease HVA, because if we don't have dopamine to begin with, we're not breaking dopamine down.
And what breaks down dopamine to HVA? Two things.
MAO, and then COMT.
Mm-hmm.
Yeah, MOA. Yeah. Okay. And norepinephrine and epinephrine as well. What about serotonin? Just monoamine oxidase.
Mm-hmm.
COMT is not involved for serotonin. Yeah. Good job.
I'm sorry, guys, for interrupting. Where did you point out that there is a low dopamine?
Go ahead, Lindsey.
Low dopamine is because of Parkinson's.
Oh, my apologies.
Yeah.
Thank you.
Yeah. No worries. We're here to help. Yeah, Parkinson's is due to the dopamine. You guys are going to get a lot into that in NB. So the only thing in ER that you need to understand is that Parkinson's is low dopamine. And then, of course, dopamine, the metabolic end product, is going to be HVA.
And what disease will cause A in the urine?
Yeah, A.
Which one?
Pheochromocytoma.
Yep.
Exactly. Yep.
Because this is the breakdown product of what?
Epinephrine, norepinephrine.
Yeah, which are also called
catecholamines.
Catecholamines, yes. Good job. Aw, Phoebe. You can hear her snore. So there is a buzzword in this question. And if you know this buzzword, hopefully it'll narrow it down. Most of status, SP is status post. Oh, I forgot to hit start on my timer, so I'm gonna give you guys a few more seconds. But you're all getting, most of you guys are getting it right though. Ectomy, the suffix ectomy means removal of, you're cutting it out. Giving you guys about 5 more seconds. Okay. Primary hypoparathyroidism is the answer, and your buzzword is thyroidectomy. You might be asking yourself, well, why do we have hypoparathyroidism if we have a thyroidectomy? Does anybody know the answer to that?
Due to accidental damage?
Yeah, they're very closely associated with each other. They're very closely associated with each other. And so if you have accidental damage or removal of the parathyroid, then you can get the primary hypoparathyroidism. And it's primary because it's at the level of the actual organ. It's not somewhere else. So that's why it's not going to be secondary hypoparathyroidism.
But if you did see secondary hypoparathyroidism, I mentioned that vitamin D is usually the culprit, right? So if you have, for whatever reason, you have decreased rickets or osteomalacia, that could cause a secondary. It's not a problem with the actual parathyroid gland. It's secondary. Or I'm sorry, that's actually for hyperparathyroidism, excuse me, right? So if you have decreased vitamin D absorption in the gut, then you can get secondary hyperparathyroidism because of the low calcium levels.
Or renal failure. Had someone put that in the chat. That's another thing. Make sure you know, I don't have a question about this, but it's really important that you know the lab values, the urine and serum lab values for hypo and hyperparathyroidism. TBI is traumatic brain injury. ADL is activities of daily living. Yeah, I'll explain central versus nephrogenic when we go over this question. Okay. Okay, we are going to have an increased urine osmolality after DDAVP administration. So, thank you, Brady.
I got it.
So we have central diabetes insipidus. So before we go over the specific thing, I'll tell you the difference between these two. Central diabetes insipidus means that you have a decrease in ADH at the level of the brain. If you have nephrogenic, you have ADH, but you don't have the receptors for ADH in the kidney. And so it doesn't matter how much ADH you produce from the brain, you're not going to have the effect of ADH because in the kidney, you don't have the receptors and it's not going to react to it. So that's why the urine osmolality is not going to change if you have nephrogenic diabetes insipidus, because it's just, there's nothing to react to. But so we have diabetes insipidus. That means that your urine osmolality is going to be kind of low beforehand. And then when you administer the vasopressin, that means you are going to get the introduction of the channels. You're going to reabsorb the water. And so your serum osmolarity is going to decrease and your urine osmolarity is going to increase because you are retaining water after the introduction of vasopressin. Does that make sense? Awesome. Anybody else have questions on that? Do understand the difference between serum and urine here. They can ask you, they might ask you a question like this, but of course they could ask you anything to interpret the serum and urine osmolarities. They could say, give you lab values and what would you expect to see in a patient with central diabetes insipidus, and it could include serum osmolality in that.
So what was the key term in the vignette? Because I was like the fact that the patient was peeing a lot at night?
Yes. Okay. Frequent urination, and then it results from a TBI, from a traumatic brain injury. So this is going to tell you it's most likely going to be central diabetes insipidus, but then he's peeing a lot. But actually, the only thing you really need to look at is this: which of the following would confirm a diagnosis of central diabetes insipidus? That sentence right there, you can ignore the rest of this question, honestly, and you could still be able to answer it. But the rest of the information kind of supports the diagnosis of central diabetes insipidus.
Thank you.
I think this is one of the last questions. This is either the last or second to last, I think. Okay, now we're getting some correct answers in here. Remember our distinction. Okay, we are talking about a woman who can't breastfeed, but she has production of milk. I don't know how to say that. She has production of milk, but she doesn't have any letdown. She can't actually eject the milk. So which hormone are we talking about here?
Oxytocin.
Oxytocin. So what is the only answer choice that is going to relate to oxytocin? It's A. It's magnocellular neurons. Parvocellular are going to be more related with prolactin. Lactotrophs are these cells that are going to produce prolactin. The gonadotrophs have nothing to do with this. Well, it could indirectly have something to do with this, but gonadotrophs are going to be, actually, no, they don't. This is going to be GnRH and then LH, FH, all of that stuff.
And what about B? What's that involved with?
It's prolactin. It's the median eminence. It's more the median eminence, but downstream it is going to.
Well, I was just saying A versus B.
Oh. Sorry, guys. Yeah.
Pituitary.
Yeah, anterior pituitary versus posterior pituitary.
Good job.
Yeah, and the way I remembered this, and this, I don't know, this is kind of a simple way, but N, so the neurohypothesis is kind of like 1/2 of the M, magnocellular. It's kind of dumb, but that's how I remembered it.
Sorry, can you explain this again?
Yeah. So we have difficulty with breastfeeding, and evaluation reveals normal production of milk. So if we are producing milk, we know that prolactin is normal, but we have no letdown of milk, which means oxytocin. Oxytocin is needed to actually have that ejection of milk from the breast. So, which are going to explain the symptoms. We're talking about oxytocin, destruction of magnocellular neurons. Magnocellular is associated with the neurohypophysis, also called the posterior pituitary. Parvocellular is going to be anterior pituitary adenohypophysis. This is going to be more prolactin. So if we said that she cannot produce milk, you would look towards parvocellular, but you could also look at the lactotrophs, because the lactotrophs are the cells in the pituitary that are going to be responsible for the synthesis of the prolactin, whereas parvocellular neurons, these are going to be at the level of the hypothalamus, and it's not going to be at the level of pituitary. So if you wanted to distinguish between these two, they would have to tell you something additional in the stem to know it's at the level of the pituitary versus the level of the hypothalamus.
And watch this. Let's say you couldn't remember which one, if it was oxytocin or prolactin, right? You couldn't differentiate the two. Well, B and C are saying the same thing, right? They're both relating to prolactin. So if you were between oxytocin and prolactin, you could go ahead and cross these out because they both can't be correct, right? So use the test to your advantage.
Yeah. You guys are doing a good job with this one. This should say decreased. I got a little carried away there with typing, so that should say decreased. I will correct this when I release it. But what are we seeing here? So generalized fatigue, that's really nondescript. It's not really going to help you answer this question. But when we get to the lab results, we have high aldosterone, which can actually narrow down your choices right here. So if we have high aldosterone, We are going to rule out diabetes because this isn't going to be associated with it at all. Cortisol levels are normal, so it's not going to be Cushing's because Cushing's is going to be high cortisol. And then SIADH is nothing really that's going to point to syndrome of inappropriate ADH. So I would cross that out as well. And then since we're doing high aldosterone and Addison's is going to be all levels decrease, and it tells us we're looking at Conn syndrome. Any questions on that? I'm glad most of you got this correct. Okay, I think that's my last question for you guys. It is because it's not moving forward. You guys have been fantastic. Thank you so much for attending our session. Again, recording, review, and the questions and answers will be posted later today, most likely. If you guys have any questions, please reach out to us. Good luck with the repro stuff. We will let you guys know when we plan on doing a repro review.